Thank you. So this session will have a plenary speaker, Ibrahima from St. Louis. I'll give you a bit of introduction about him, and then after that, we'll have a panel, and the panel would David Rees, Manuela Ambrose, Onazi, Patience Kona, Lumba Osongo. So had the privilege of introducing a friend and somebody I've met at different events, avenues, and Professor Ibrahima. He is the Director of Research, Cooperation, and Ecological Information at the UGB. We're talking about a few ambassadors between Anglophone and Francophone, and Ibrahima is one of them. It's on the Francophone side. Ibrahima is a privilege to listen to you to talk about the clinical management of sickle cell disease in Sub-Saharan Africa, and talk to social some of their experiences on the local sites. Ibrahima, over to you. Thank you.
Thank you, Chairman. This go to, how does it work? And, thank you, Chairman, and many thanks to the organizer for the honors for me to be welcomed in this symposium. And congratulations to Professor Balandya and all the organizers for the quality of this symposium. And I will apologize for my English and would advise you to more look at the slides and hear what I am telling. I'm asked to talk about sickle cell management, clinical management of sickle cell disease in Sub-Saharan Africa, and I have to remember some backgrounds. There are more than 120 years that James Eric reported the first case of sickle cell disease in a young student from Grenada whose name was Walter Clement Noel. And while he was admitted in his service for lung infection, one of the main problems of sickle cell patients. Walter Clement Noel went back to his country and is the capital, St. George, and died when he was 34 years old by acute chest syndrome. And he was buried in the Soto Cemetery in the north of the island, overlooking the Caribbean Sea, as you see in this picture. From this case, we learn that infection is one of the main problems in sickle cell patients. And in the adulthood, acute chest syndrome is one of the main causes of this. In Sub-Saharan Africa, sickle cell is one of the main public health problems because of its frequency, morbidity, mortality, and the big problem we have to access to treatment and diagnosis. There are many challenges for comprehensive management of this disease based on prevention and care. It is known that Sub-Saharan Africa has the biggest burden of sickle cell disease, since 70 to 75% of the patients are born in this area, and mainly in Nigeria and DRC. This frequency could be explained by the pressure, the selection pressure of malaria in the sickle cell traits in the same geographic area. Since it was being demonstrated that sickle cell traits, hemoglobin C and alpha thalassemia have a protective effect against several forms of malaria, which is one of the main cause of this in childhood and in the general population without prophylaxis of this problem. While hemoglobin S gene is a single mutation, there are many variations in morbidity and mortality according to many different factors as environment, physical, socioeconomic, sanitary, but mainly because of genetic factors, with which the main genetic factor is haplotype and persistence of hemoglobin F. There are described 4 haplotypes in which, among which 4 are in the Sub-Saharan Africa. And among these haplotypes, the Senegalese haplotypes type appears to be associated with better health in patients compared to Bantu or South Africa haplotype, which is the worst. And Benin is intermediate between these two haplotypes. Generally, if you look what happened in the high-income countries, we see that since programs are made in these countries, for example, in America, since the Sickle Cell Act of President Nixon, you have a very decrease in child mortality, and about 94% to 99% of children reach adulthood in these countries. And through the years, the life expectancy grows very regularly. This is mainly due to the reduction of the mortality of children with sickle cell disease, as you can show it in these different pictures. And one of the main causes of disease are infection in this area. And when we adolescence and adulthood, all the disorder of the organs failures can become a very important problem. In Africa, Sub-Saharan Africa, child health mortality remained very high through the years and didn't decrease clearly. And you have many reports that showed that it is a very great problem in Sub-Saharan Africa. Report from Tanzania, from Senegal, and from Kenya showed contribute these concepts. In a research study in which we participated in Western Africa, in five Francophone countries, we showed that the under 5 mortality is very high. Even it doesn't reach the value usually told. In this study, we showed that the mortality was from 17% in Mali and rise to 55% in DRC. It is clear that this mortality is underestimated, as said Professor Odame last day. And since this study was a retrospective study with its limits. While sickle cell disease mortality is become very low in the high income countries, it continue to be very high in our countries, because in the first case you have less than 20% of children we die before 20 years, and in African setting, 35 to 40% of children under 5 die before the age of 5. And the main cause are bacterial infection, anemia, stroke, and in adulthood and adolescent, irreversible organ damage. In this context, what are the challenges to be addressed? The last day, our different presenters showed the importance of many points which would be addressed for struggle against sickle cell disease, policies and dedicated program, training and guidelines, infrastructure and organization. These to address the main problem, what are newborn screening or any other strategy of early diagnosis, antibacterial infection and malaria prevention, specific drugs like hydroxyurea and safe blood transfusion would be the main problem to be addressed in our setting. Since 1990, there are different directives that have been given struggle for sickle cell disease in Sub-Saharan Africa. But to see the international organizations like WHO and the United Nations to address, to recognize sickle cell disease as an important public health, and that directive had been given. And then WHO The program for the university diploma. This group develops the guidelines. It's applicants to these all the working group. What we observe is there are numerous national guidelines. And some international guidelines from Africa or friends. And these guidelines need to be adapted. And what would be the best is to develop a consensual guideline for Sub-Saharan Africa. And who would be, what would be
and in our setting in West African Africa, Francophone West African Africa, we develop a guideline for Africa. We address the problem is different from the same model. And these guidelines are used with adults during the Nachega Symposium in Senegal in 2018. We adopt all these counties as reference guidelines for sickle cell disease in the
guideline and you also
Oh, but that's, it's not C2C. Is it? It's fine.
says that comprehensive care, standard comprehensive
No, it's not
care,
C2C.
must be adapted in the
according to early diagnostic. If it could be in newborn setting, it would be better, but all kinds of all strategy of early diagnostics, the regular flow of patients, prevention and treatment of bacterial infection, prevention and treatment of malaria, which is a problem which is specific to Sub-Saharan Africa. And we don't forget the nutrition problems, since nutrition is a very big, malnutrition is a very big problem in our setting. Early diagnostic and treatment of complication and specific treatments like hydroxyurea, transfusion, and also specific treatment according to chronic complication. Newborn screening and penicillin prophylaxis and pneumococcal vaccine has largely demonstrated their interest in preventing from severe infection and from these early disease. Newborn screening programs exist in most of our countries, but they are already always pilot programs and no national programs. The method used are the standard methods that are used in the developed countries and which is very expensive. The different strategy used are systematic screening in these pilot studies. In some rare cases, like in Benin, that was targeted screening. Usually it is right after childbirth, and it can be continued during postnatal consultation. Some alternative have been developed in Nigeria as screening during immunization program. In this country, a multi-state approach shows that these newborn screening have a very huge cost and have a problem of inability to maintain the program because it is very expensive. There is CONSA experience. We shown that newborn screening is very effective to prevent early child death. And even the newborn screening are mainly pilot studies. They have at least the interest to give the real incidence of sickle cell disease is in several countries in Sub-Saharan Africa, as you see in this slide. Without newborn screening, in our experience in Senegal, after 20 of follow-up of patients, we showed that less than 2% of patients have diagnosis before 6 months, while more than 20% of patients are diagnosed after the age of 10. This is very problematic. And usually the signs and complication of the disease are the occasion to have the diagnosis. The other interest of newborn screening in our experience is to show that when you go from Dhaka, the capital, to Saint Louis, where I am working, less than 300 kilometers, you have very difference in the type of hemoglobin abnormalities, and this could be a problem to be addressed. The problem in newborn screening is a very expensive cost of the method you use, and it is demonstrated that we can have screening, but perhaps not in the newborn period, but in the early other periods by using rapid diagnosis by point of care tests. And there are many different point of care tests you can use, qualitative or quantitative, but we have to develop it in newborn to see if it is very, it's something which could be used. WHO has added the point of care test in the list of essential in vitro diagnosis, and asked to every country who have high prevalence of sickle cell disease to add it in his list. Then the second point of after newborn screening in managing sickle cell disease is the prevention and treatment of bacterial infection by oral and body food hygiene, immunization, penicillin prophylaxis, and early diagnosis and treatment of severe infection. You see, body hygiene, this is by counseling, oral hygiene, and so. The immunization program in most of our countries include conjugated pneumococcal vaccine with 13 valence and Haemophilus vaccine against Haemophilus influenza, this is a very important thing in our program. The main problem is after the age of 2 years, the polysaccharidic vaccine against salmonella and against pneumococcus is not available in this program and need to be paid by the parents. It is a very big problem and it is very expensive. According to about the severe infection, one of our problem is the cost and the availability of antibiotics in some severe infection like since it has been clearly demonstrated that hydroxyurea have reduced an important role in the reducing mortality in the is about 20 for 1 month of treatment of size of 30 kilograms. It is very, very, this cost is very high.
That's just, there we go. Please go ahead.
Okay, should be fine. Donc, according to transfusion, the simple transfusion issue is not a problem, but the main problem is to make transfusion program because of the risk of immunization,
iron chelators are too expensive and not available. Citaferase devices are too expensive, and there is a problem of availability and safety of fluid transfusion in some countries. I am finishing to say that the 3 pillars of management of sickle cell disease are early diagnosis by screening and training health workers to give effective treatment for sickle cell patients. And this would be need clinical research every time to identify the best approaches for sickle cell management. And I am finishing that. Thanks to Reon Shilolo, to Obie Jeli Nudu, and all the person who shared with me their slide for prepare my presentation. Thank you.
Ibrahima, you may be very surprised that I did not need to look at the slides. I absolutely enjoyed the presentation, and I got a lot of new information as well, believe it or not. So thank you very much for that good presentation. I mentioned the panel, and I have one of the panelists, Professor David Rees. He is a pediatric hematologist at King's College Hospital, London, and King's College London University. He has interest in sickle cell disease, thalassemia, and other inherited red cell disorders. So I think David is online. David, are you? Okay, I will just introduce David, and when he comes on, he can join us whenever he comes on. So he is a particular interest in cerebrovascular disease. He's also interested in the mechanism of red cell disorders, red cell damage in sickle cell disease. He's involved in the care of over 1,000 patients in South London, and a medical advisor to the Sickle Cell Society. So David will be giving a very summary of the Lancet Commission recommendations. So I think he can come in at any time, at least during the presentations. So we will probably therefore invite the panelists to the table, and I would like to take it in this way. I will introduce the, so we're going to have Dr. Emmanuel Ambrose. She's going to come up to the higher table and just sit there so that she can be joined with the others. Emmanuel is a pediatrician and lecturer who has devoted her clinical practice and research in hematology, especially sickle cell disease. In her very young career, Emmanuel has done quite a lot of milestones and has received a number of grants and from the American Society of Hematology. And also I remember that I was one of the ones that evaluated her application for the Global Research Award, and it's a very highly competitive research award. So Emmanuel would also, as a pediatrician, would give some perspective, particularly in the approach of managing patients, and particularly the use of TCD. The next person would be Bonia Yonazi. He's a hematologist working at this hospital with 8 years as a practicing hematologist and with a keen interest in hemoglobinopathies, bone marrow failures, and hematological malignancies. He serves as the hospital board secretary, and also which has really kind of led to implementation of the bone marrow transplantation and myeloma. He's a member of the technical working group for sickle cell disease at the Ministry of Health. And then I'll have the other people who will also come up and join us. I have Patience Corona. Patient Corona is Sishas, Zimbabwe. He's a pediatric hemato-oncologist and senior lecturer at the Children and Adolescent Health Unit at the University of Zimbabwe. She's been a very active member of the Sickle in Africa, and a very passionate one as well. I also introduced Luimba Kosongo, who needs no further introduction because she came out yesterday and gave a rounding, strong, passionate position about the patient position. And we had her story yesterday, but she's chosen not to give her story today. She's going to talk about the story of all the patients in terms of their experience in clinical management. So I think just do a signal to me when David Rees comes so that he can show his slides online. I don't know whether I have a second microphone. I do? Okay. Okay. So I'm going to start with our host, the Tanzanian group, and I'm going to start by just no, it's not by kind of bias, but I'm going to start with the pediatrician. So Manuela, maybe you could start the perspective of they'll have 5 minutes to give their position, and they can take slightly longer if they need to. But we'll start with Emmanuela and go to Imbonia. Emmanuela, do you have slides or you want to start from there?
I don't.
Great.
Hello? Okay, thank you. So as I've been introduced, I much work in sickle cell, and at our hospital, I'm dealing with pediatric population. We have a large number of patients with sickle cell disease, and I'm at a tertiary hospital. Not all are being able to attend the tertiary hospital. So the experience from the management from our part, we do comprehensive care of sickle cell disease. And currently, when we diagnose patients from when they report to our hospital, we do the basic screening, basic labs to identify their disease. And we are happy that we have diagnostics that can tell the type of sickle cell they have. And also they can tell us the percentage of their fetal hemoglobin, as we have heard from the presentation, that fetal hemoglobin plays part in reduction of the complications that these patients have. So my interest in this topic, I will go direct back to my practice. We have high number of patients who are getting stroke. And knowing that majority are getting stroke and it is a debilitating condition, when these parents are coming with these children with stroke, they're really in a depressed mode. So what we discovered at my hospital, initially we studied the prevalence of stroke to our patients. So we went and ruled out the complications, and we found stroke was in high percent. And because it's a tertiary hospital, majority of those with more complications are coming to our hospital. So through the grant that I received from the ASH Global Award, we were able to secure a transcranial Doppler ultrasound machine. And this is the machine that is screening for the risk of a child to get stroke. It's a simple tool with no side effects to the child. And it directs, go to your cycles of Willis, if we remember our anatomy, through the spaces in our bone, and direct it goes and check the velocity of the blood vessels. When the velocity is higher, is when you recognize that this child is in a risk of getting stroke. And what we discovered when we did screen our children, and we found that they're having a very high risk of getting stroke, we said, what can we do? Because the best management for those who are here who understand is disease-modifying therapy. And on the developed world, they are giving blood. And they give blood in chronic basis every month. And this is more of the exchange blood transfusion. And at that time, we had no exchange blood transfusion. What we were doing is a partial manual exchange blood transfusion, which, yes, it helps, but it's not as effective as the automated exchange blood transfusion. And the partial manual exchange transfusion, you may be, it need a lot of people, a lot of time, yeah. And accessing veins in these children, especially very young, sometimes is a challenge to get enough blood out of them and to give them. And we have heard from our senior on alloimmunization effects. So what we said, let's use hydroxyurea in trying to prevent this stroke to these children who are at risk of getting stroke. So what are we doing? We are providing hydroxyurea to these children who are having high risk of stroke, and not the blood transfusion because of accessibility of blood in this an extensive screening of a blood that we have. So we got tremendously effect by using hydroxyurea. And because they're at risk of stroke, what we used hydroxyurea to those who are at risk by escalating the dose of hydroxyurea, not as the normal dose that we use on other children who are not on, who have no risk of getting stroke. And we did this for those who had a velocity of above 170. And I'm telling you, in doing this to our patient who had a risk of getting stroke, there was a tremendously drop on the velocity of their, on the velocity at their cycles of Willis. And majority of them, there was a mean drop of about 40 centimeter per second on these children who had hydroxyurea. We went to use hydroxyurea to their tolerated dose. So we were doing labs at least 3 monthly and not monthly. And that worked. And no one from this group had developed stroke to today. And it's about 5 years ever since we initiated stroke. We initiated the hydroxyurea high dose, and the children are really in their bouncing ways. They're going to hospital. They, I don't see them in the wards as I used to see them before. They don't get blood transfusion. As they really are there, we follow them up 3 monthly, in 3-month basis on their medication. So what I discovered, despite that we used hydroxyurea in preventing this stroke, but they improved in other complications that also present in sickle cell disease. No acute chest that they report with, vaso-occlusive crisis of other means, they don't report with. And I'm happy that their kidneys, liver are okay because the dose is still causing them to have less myelosuppression, and they get a very good effect of hydroxyurea. But to these other children who were treated with normal, some with no hydroxyurea, we say hydroxyurea to all, but no, not all patients that can access. But we wish like everybody has to be on hydroxyurea. So those who were on hydroxyurea on other bases, they still improve on hydroxyurea. But we get some reports, or very few that are reporting with stroke, and that we need to study. Why are they getting stroke? Are they probably need to screen? Do we need to screen everybody on TCD? I can say yes. It's just we need a different probe, but the same ultrasound machine that will be needed to screen stroke. And we don't need a high profession somebody to do transcranial Doppler. We use the ones we have. For me, even a nurse can do a transcranial Doppler, as we trained a nurse to do, and she's very perfect doing transcranial Doppler ultrasounds and can detect early. And even a radiologist, a radiographer can be trained on doing the transcranial Doppler and do the job and get the results that can prevent these children having stroke. Despite that, we give these children hydroxyurea, also they need assessment to other complications apart from the stroke that we base on. And I found that it's good that I share this because these children, when they reach 7, 10, is when highly they present with sinus symptoms of stroke, like they come with headache and they come with inability to use one side, or they were not able even to write acutely at school. And with that means we need to prevent them from this debilitating, because when they get stroke, even the parents cannot work efficiently. They'll be thinking of this patient who is at home and cannot do anything, who need to be fed. So if we help this child to prevent this child from getting stroke, even the parents will have a time to work and provide for the family.
Thank you. As introduced, my name is Dr. Mboneo. I'm coming from Wimbili National Hospital, the birthplace of sickle cell disease program, which has greatly changed the landscape of treatment of sickle cell disease in the country. And perhaps the reason why we are here today, a great work by Professor Julie Makani that is now being spearheaded by Professor Balandya and the team. So we have heard from the pediatrician, they're doing a great job. Similarly, at our center, we do see an average of 1,500 patients monthly. That is being pediatrics and adults, 2/3 being the pediatric population. But amongst all, only 2/3 again are on hydroxyurea. We have been enjoying the use of hydroxyurea mainly amongst the pediatric population through the total AFIA card, the NHIF scheme for the children. But currently nowadays we are observing challenges because now that scheme has been abolished and now children are not being able to access the hydroxyurea, the very medication that is required to change their well-being. We have clinics daily nowadays, thanks to a dedicated clinic space that has been set aside for sickle cell, owing to the a big population of patients that we are seeing. So pediatricians, adults, hematologists, and registrars will be seeing these patients on a daily basis. Simply and shortly, just to say what we are observing as emerging challenge, or one of my colleagues called it a blessing, because of the good work and care improvement in sickle cell. We're increasing, and we are seeing an increasing cohort of patients with aging. Actually, it's an aging cohort. These children, we used to lose them in an early life earlier, but now they are in their 20s, now 30s, and we are having emerging challenges because they have accumulated organ damage, nephropathy, cardiomyopathies, pulmonary hypertension, avian, and now the need for referral and linkages. You see a patient in the clinic and he or she is in her mid 20s, and she tells you, doctor, every good person who gets to know that I have a sickle cell, once they know that I have sickle cell, they shun away from me. They run away from me. I cannot go to work. I cannot access my studies very well. So we have growing psychosocial issues, but also we have a challenge with the transitioning. They are being very well attended and pampered in the pediatric side. But when they have to transition now to the adult side, they see new faces, new people, new procedures and setup. It's quite a challenge for them. Some they are lost to follow-up. Some they become non-compliant to clinic attendance and use of hydroxyurea. So we have a challenge that we are working on. But what have we done? We are privileged to have other centers with us, Jakaya Kikwete Cardiac Institute. So at Jakaya Kikwete Cardiac Institute, we have a specialized sickle cell disease clinic that would see these patients with cardiomyopathy or cardiac-related complications. But we have a nephrology unit at Muhimbili National Hospital with nephrologists seeing our patients that have sickle cell nephropathy. They are not few. We also have Muhimbili Orthopedic Institute. So we have quite a number of our patients with avian attending the orthopedic clinic, some undergoing total hip replacement, some are on the list waiting for the proper age to be able to undergo the procedure. But it's not cheap, it's expensive, and majority, again, they are being left out. Possibly an area of improvement in the care of a patient with sickle cell disease, as this now we are observing is an aging population. Another thing that we have recently noted is a need for conception and delivery for the females. Now they're in their reproductive age. They want to live normally as other females. And we do see complications, pregnancy complications, challenge deliveries. And we have had to open a specific clinic for sickle cell and obstetric at our facility, which has seen an improved care and a safe delivery for our patients with sickle cell. Yes, we do exchange program, blood exchange program. We do manual, as Dr. Ambrose has said, again with its challenges of immunization. Automated, we have the ability and skills to do, but again, the cost of accessing the apheretic kits is quite a challenge for our patients. So only a few again can be able to afford the service. What we're also seeing as a challenge is a fragmented care, specialized but not necessarily holistic. So you have a child who is growing, attending sickle cell disease clinic, but not really being very well followed in terms of nutrition. Though we have nutritionists, we not really being followed in the manner of growth, because as it has been said earlier here, they are stunted because of endocrine issues. And therefore we have endocrinologists in the pediatrician, but we don't have a holistic package that mandates the care of children with sickle cell disease so that they may grow normally. We do have challenges every day. Shall I live to achieve my goals? Doctor, shall I ever have a wife or a husband? Shall I be able to bear children? Shall I ever get employed? Those are the hard questions that we do get at the clinics. We wish to have had a psychologist or people of that nature to be able to cater for those questions. But we are glad we are moving. Amongst us, Chair, may I also introduce Dr. Catherine Mhando, if you may stand. She's our senior resident in hematology. She's a sickle cell. So we have examples of improved care. They do pass it and to achieve their life goals. Thank you.
All right, so yeah, so thank you for your presentations, Tanzania. I think we go straight to Zimbabwe. Thank you for another 5 minutes. Thank you.
Thank you. I'll try and speak under 5 minutes, Pap. My name is Patience Kwona. I'm a pediatric hemato-oncologist, like already introduced by Baba. I work in Harare. I'm a lecturer at the University of Zimbabwe. And I sort of started a pilot registry when I was a MIPI Junior Faculty Fellow in 2016, after realizing that when we went to the pediatric hemato-oncology unit, a clinic, majority of the patients there were patients with sickle cell disease, and we didn't have a plan for them. So we just sat there and said, what do we do? So we said, okay, maybe let's see and try and quantify the problem. While we were just sitting there, we realized that actually these patients needed a plan because there were many and they tended to come to hospital very frequently. I think I had a patient who had by the age of 11 years, 43 admissions at the hospital. So that work then has led us to applying for a grant to participate in the Sickle in Africa. And today I just want to highlight that it has taken me out of the central hospital to the peripheries where we are now working in 3 rural provinces. But we are still counting. It's still about epidemiology and mapping so that we can convince the policymakers that these patients exist and they need a service. And thankfully, we have partnered with our patient partners. There's the Sickle Cell Anemia Trust Foundation in Zimbabwe, who are quite active. And I must say, now we enjoy political support, not as much as Tanzania. We are still waiting for the politicians to put money to their words. But I think, that's the beginning of the journey. So I will highlight the inequity in terms of service in the peripheries, what I have seen and what is available at the Central Hospital, where we have 5 adult hematologists. We've got so many pediatricians, 3 hemato-oncologists, pediatricians, and general pediatricians running a reasonable service. But we are not able to offer newborn screening in Zimbabwe. We do offer, I think it's a reasonable vaccination package for our patients, including the pneumococcal conjugate vaccine, but the government is only providing the primary doses with no boosters. We have HIB in the program, and in terms of prophylaxis for infection, we do offer penicillin prophylaxis. We have challenges with accessing the penicillin V, the oral pen, but we do have amoxicillin, which is available all the way to the primary healthcare centers. We have folate, mainly for pregnant women. So somebody then decided, let's combine folate and iron, and bringing a big issue for us. So now our patients do not have access to single folate. If it's there, they are told it's for pregnant women. So there are programs that are running in parallel. So then in terms of hydroxyurea, it is mentioned in our drug formulary. It's supposed to be available from the 2nd level hospital, but it's not there because the people there are not aware that they should order it for the patients with sickle cell disease. Same with morphine. It's not available in those hospitals because they are not ordering it. And then we've got a big challenge in terms of diagnostics. Majority of centers, including the tertiary hospital, can only offer a sickle cell screen, either the solubility test or the sodium metabosulfite test, with no access to electrophoresis, HPLC, isoelectric focusing. So, I mean, they have to pay for a confirmatory test between 60 and 120 US dollars, and that's not affordable. It's the majority of these patients will not have a confirmed sickle cell disease test. You have to look at the clinical history, and in the tropics, you wonder how many sickle cell traits with other causes of anemia are actually being looked at as sickle cell disease. So the biggest issue we have is awareness and diagnosis. The patients don't have a diagnosis. Late diagnosis then happens because of the frequent utilization of the hospital service, and you're now using the clinical diagnosis. So in the process, we are losing quite a number of children who die without a diagnosis, but they are labeled malaria, pneumonia, malnutrition, and all the other complications. I think I'll stop there. Thank you.
Thank you, patients. Actually, I would like to have our patient Lumba to give us the last message, but before that, I would like to listen to David Rees, who is online. He's going to summarize the Lancet Commission, the recommendation. So, David, if you are here, we would like you to.
Yes, I'm here. Can you hear me?
We can hear and we can see you. Thank you.
All right. Okay. Well, thank you for allowing me to speak this. Obviously, I can't say anything really about managing sickle cell disease in Africa, having worked in London all my life. But I just listened to the talks. I've learned a lot. And I think I guess my role was to talk briefly about the Lancet Hematology Commission, which I know was launched yesterday, but probably to repeat some of what was said yesterday, it arose really from the situation with sickle, that things seem to be changing really in several fronts, and it seems like there's it's an important point for the management of sickle cell disease in all countries really. Firstly, as we've heard, there's a great there's a lot of activity in Africa and important research and clinical developments going on, and increasing awareness of the sheer scale of the problem, in Africa particularly, but across the world. And secondly, there are new treatments being developed, really, both, although nothing much has come through to sort of clinical practice so far, there are new drugs being developed, small molecules, and also potential for curative treatments, with stem cell therapies and gene therapy in particular, which in the distant future seem likely to offer a potential cure, across the world, although we're a very, very, very long way from that. And thirdly, there's a general feeling that sickle cell disease is neglected and outcomes at a different level. There's a great deal of dissatisfaction in the UK and the States and high-income countries with how patients are managed, although for us childhood mortality is very unusual, and the majority of it's actually the survival of children with sickle cell disease in, say, London is pretty much the same as those without sickle cell disease, but there's still that changes in young adults, and also there's a very strong feeling that people are not treated equally. There's in the UK and other countries, there's dissatisfaction with how quickly people get paid, the standard of care that they get, the institutional racism towards some of their management, reflected more generally in the fact that there are relatively few treatments for sickle cell disease compared to other conditions like cystic fibrosis and haemophilia, which are rarer, certainly in the UK and I think across the world, and have a great deal of resource and treatments available to them. Whereas in sickle cell disease, still the basic treatments are penicillin, a drug from the 40s, and hydroxyurea, which has been around for a long time. Although it is, as we've heard in Africa and in the UK, is remarkably effective, it's certainly still not curative, and it's still not the case that it's so good that we can stop trying to make things better. So the idea was to focus on looking ahead to maybe over the next 40 years to what things could be done and what changes could be made to try and improve outcomes in sickle cell disease. And the group of, I think, about 30 authors the idea was to make it, multinational, multidisciplinary, and there is a wide range. I think there are authors from, there are 30 or so authors from 20 or so countries, covering a range of interests from epidemiology and health economics and obviously hematology and sickle cell disease and pediatrics. And it looked at, really, there's obviously a huge range of possible things that could be spoken about, but could have been talked about, but we chose to focus on 5 areas. One was, as we've heard, epidemiology, just understanding the scale of the problem and how many patients there are and where they are, and to get some idea of, how, the natural history of the condition in different settings. Then again, as we already heard in some of the talk, screening for the condition and trying to identify, the key thing to providing care is to know who the patients are and to try and identify them before they present either seriously ill or in many cases in children before they die without a diagnosis being made, and so to try and develop neonatal screening essentially across the wide range of countries. As we've heard, there are some established treatments, particularly penicillin, and prevention of infections and hydroxyurea, and trying to increase the provision of that. And the things we've heard are, it's encouraging that, well, there's a lot of what we know about hydroxyurea, has come from studies in Africa, and our practice in London has been influenced by studies in Africa showing the benefits of high dose hydroxyurea, escalated dose hydroxyurea, but to try and make that widely available to everyone with sickle cell disease in Africa and India and across the world. And then, as I mentioned, the other areas looking at new and cellular therapies, and although it's some way off, the potential for widening access to stem cell treatment, in particular gene therapy, and in the very distant vision, the idea that maybe in vivo gene therapy, gene therapy without the need for myeloablative conditioning might be developed and might be a potentially deliverable, in all sorts of health settings across the world. And perhaps, and again, very importantly, looking at training and education of healthcare providers, and that there are, in London, in the UK, it's difficult to find enough experts in sickle cell disease to look after patients, and that problem seems to be magnified many fold in many countries. So to try and look at establishing training and developing expertise amongst nurses and doctors and psychologists and physiotherapists and all the related medical professions, like, as we've heard, obstetrics and orthopedics, trying to develop relevant sickle cell disease expertise in all those areas. So those were the 5 main areas of the commission. Obviously, so far it's achieved nothing other than stating that some recommendations of things that should be done in these areas to improve things. And hopefully the idea is that this is very much the start, that there are other things that need to be developed, and that the recommendations will be monitored, and hopefully, to some extent, hopefully governments and the relevant authorities can be held to account against these standards, if so that things improve in the future. Thank you. I think that's probably all I've got to say.
David, thank you very much. We will have one more speaker, and then we will have questions and answers. And if you could stick around to please address some of the questions. So I hope you will still be available. And I will also encourage those online to kindly post your questions. Those who are here in person, please, could you also prepare questions for all the speakers? I'm going to go to Limba, the patient voice, in very many ways. I think we've got slides. You just want to talk? No slides.
No
I know you have them, but it's okay. Just go ahead and talk. We want to hear your perspectives, and then after that, I will just try and highlight some points, and then we'll open the floor for discussion. Limba, thank you very much.
Thank you so much. I'm here to speak on clinical management from a patient's point of view. So first of all, as a patient, I want to come to the hospital knowing that I'm going to get value for where I'm coming, right? So everybody has clinics, but when I come to the clinic, you give me a prescription and you find that the only drugs that are available are folic acid. Not even Deltaprim is there. Hydroxyurea is not there. So what benefit do you want me to keep coming to the clinic if I'm coming to the clinic and there are no drugs? All right, then there's loss to follow up. You're always complaining about loss to follow up. But for example, newborn screening, you do the screening, but what benefit are you giving to the mother for her to come back? Because when she's coming back, first of all, there's no counseling sessions. You don't have time to explain to her about it. For example, in my country, we utilize the support groups to make workshops to explain these things. Dr. Chunda will tell you that red exchange blood was just introduced recently, I think last year. It's still on trial. So the patients that were being recommended for red blood exchange did not know anything. The parents did not know anything because, I understand doctors have a lot of very little time. You just said 1,000 patients. In my clinic, 45 pediatrics, 10, 12. So what time will you have? So they get confused. What is red blood exchange? What do you want to do with our children? What do you, so what we've done is the support groups, we organize the workshops and then we call the doctors to explain to the patients, and it helps that way. And they learn so much from the support group. So these are the things I'm talking about. What value are you giving me? Quite all right, you've told me there's a clinic, you've told me there's hydroxyurea, but I can't even access it at the hospital. I use my national health scheme or the private. I buy it out of my own pocket. And then there's psychosocial, like I say, the transitioning. All right. Most of adults actually will tell you that we still refer to our pediatricians because the pediatricians, we're used to, how are you? Did you brush your teeth? How are you doing today? Oh, did you eat your apple today? And then when you go to the adult, it's like, Limba, probably you didn't even wear your jersey. They make you feel like it's your fault for the triggering of the crises. And yet, they just expect as an adult, the crises should just stop, which isn't the case, because sickle cell is sickle cell, whether it's 6 years or 60, you know what I mean? So those psychosocial things, who's going to explain to a boy who's experiencing priapism at school, 6-8 hours of priapism? He can't speak to his peers because they're laughing at him to say he probably loves too much sex. He can't speak to his parents because it's embarrassing. So how does he deal with that? Do you provide that for me when I come to the clinic to say, okay, doctor, I had priapism, so how do I handle this? No, the first thing you do is, I think you just need to go to the hospital. So now you need to, what about my psychological, the transitioning, the health talks, all those things. So I think you're doing a great job. I mean, you have a lot of patients to see. We respect your profession, but I feel like you need also take time to explain to the patients, especially when you are bringing in all these red exchange new therapies and all that. Then another thing I also like to emphasize on clinical management is that, for example, when I'm coming in with a crisis, you need to understand that I've already done the basics from home. I've taken my ORS, I've drank my fluids, I've taken my tramadol. So when I'm coming to the hospital, I'm coming to say, help me. I've done everything. But what you do, not everybody, of course, especially lack of knowledge of those that, so where are you coming from? Like time is going. By the time you realize that now my pain, I'm breathless, my eyes are popping because the pain is too much, my body is frozen because of the pain. What I'm trying to say is that you need to understand that even a mother, by the time they're coming to the hospital, they've done everything. They're coming to you to say, my savior, help me manage my pain agently. But most of the times you just focus so much on, I don't even know what to say, but I think you understand what I'm trying to say. So yeah, so clinical management really from a patient's point of view, I think there needs to be more to be done. Thank you so much.
Thank you very much, Limba. That was from the heart, and it was very useful. I think thank you for all the speakers, and I'm not going to summarize, and I'm just going to highlight some of the key things that I have got as a person listening, and immediately we'll go to questions and comments, and I'd like people to ask questions. Ibrahima actually gave a riveting talk, and I was really captivated by the fact of the organization of services in the French Africa. I was amazed about the centers of sickle cell disease, which are really kind of very impressive. And also the fact that you have targeted courses, you're running 2-week courses, 1-week courses, and courses with certificates. And then also you highlighted the fact that training is important. One of your key 3 objectives that you really highlighted. I think that is very, very helpful. I think the history that you gave about sickle cell disease was amazing because it really tells us that the disease has been for a long time. But actually, even just the story about Walter was actually very clearly demonstrating the fact that even as far back as then, people finishing practicing for 34 at the age of 34 actually was quite impressive. And thank you for your excellent presentation and your call for us to have an integration of services. And I think we've talked about integration of services, including the PEN Plus and some of the WHO initiatives, but actually translating some of this high level ambition and vision into practice. And the difficulty, despite the fact that you've been through different roles as a manager, you have not, I mean, it's difficult to still have a translation from pilot project of newborn screening in Africa into a single national, and really how can we, I think I'll have a question for the Lancet Commission. And then Manuela, discussing about your implementation of the transplant Doppler scan. Obviously, some of the questions that people want to understand is how do you make that, how is that sustainable? And also you talked about having using a maximum tolerated dose of hydroxyurea, but also we're aware of some of the low dose that was used in Nigeria, just to see which one is easily affordable and which actually can be implemented. And from the adult perspective, you explained about the growing issues, particularly people are growing into older age. What are we doing with transition again, which actually was harped on also by Luimba, that it's something that we need to make sure that we can have some model. We have reviewed about modeling in terms of transition that is almost absent and something that we really can focus on. I really like the way that patients talked about the community, particularly in rural areas where we have the majority of patients, but the services are absolutely more scanty and more difficult to implement. We need to actually consider ways to try and actually be able to reach out and to make sure how we can actually provide these services. So, and I think just again back to Luimba and the fact that I don't want, but it's interesting your comment about the pediatric experience and the adult experience. We want to make sure that all of this actually continues in the continuum, whereby you have not only the ability to communicate with your pediatrician, but also communicate with your adult consultant. But actually, we know that the service of sickle cell disease is a multidisciplinary affair, and that's why the role of nurses is absolutely key. The role of psychologists is very key, and radiologists are also very key. And we also talked about the fact and importance of having joint services between the specialists and other areas like nephrology, neurology, and also the sickle cell team, which is very, very important. So I would like to open this for comments and for discussions. I don't know whether I have any questions online before I go to the floor here. So any questions online? I can see some chats there. Otherwise, any comment, questions directed to the person you want to, I will bring the microphone to you. So Dekile has his hand up. Oh, okay. So I have questions online. So I will do that, and then I'll come to Dekile. It says, how can we have the space in the research and development of sickle cell matters? Okay, so maybe one of you can, you can talk about it. Any of you could talk about it, and then yeah, okay. So let's have that online question. I don't know when anybody wants to address that question in terms of research. How do we implement research in sickle cell management? So ignore the question. Just I'm not going to read all of them. So just anybody wants to talk about research, the role of research in Africa. Ignore the question.
I'm just wondering if this is a patient who's asking. Okay.
Yes.
For patients, I think there's a big role, like you just heard what Wimba was saying. We actually need to have patient involvement. We have learned from the previous, has changed the landscape. So we are hoping that patients with sickle cell disease will be involved. And we obviously, as researchers, would like to partner and train the patients. But we really want to learn from their lived experience to then have proper, or let me say, responsive research to their problems, so that it's very contextual.
Thank you. Any comment also about patient involvement? How do you involve patients through the research? And what stage do you involve patients in research, particularly thinking about the African setting?
From my limited experience, I think we have worked with patients from the beginning, from when we are actually thinking of applying for a specific grant to then get letters of support, to have a discussion with the patients to say what are the key things that we should probably focus on. And they're usually spot on what is needed and what we should apply grants for. And then to walk the whole journey, including community advocates and engagement. They have a better way of explaining particularly the experiences that the patients with sickle cell disease have, and to be able to then share what, in terms of the informing the other patients what
to tell some words about this about research. In our experience, we know that it is very difficult to have a person who are only in research in our clinics. We work daily for management of patients who have many data, and usually the clinician can't use these data. You have to open your sickle cell centers to others, epidemiologists, mathematicians, social workers, social researchers, and so and so. And while using this approach, we have journalists who had their memory in our sickle cell center, and social workers who have their memory of master and so and so. And we have now published a result of sickle cell patient folder while working with mathematicians and in our university. They came and usually worked while we were doing all the things. They came and worked to build sickle cell I don't know. Say it in French. Le dossier patient. Patients. Yes, the patient record, which can be used in all the country while building from newborn screening to. This was the work of the mathematician and the special of ITC, because we opened our center to others who can come and make research.
So, Mba, I know you have a comment, but let's just hear what. I know you have a comment. Go on. I think you'll go on.
Sure. Thank you very much. Let me just thank all the speakers for giving the perspectives from their different centers and countries. And it's very refreshing to see the efforts being made to provide standard care in all the places with different degrees of success and challenges as to be expected. But you see, when we talk in terms of Sub-Saharan Africa, we know for sure that most of the patients are not being seen in the kind of centers that you people work at. And I remember last night when Isaac asked Member that if there was an external funder who had so much money to give now her to organize care, that what would she ask for? And obviously she said, I mean, without hesitation, that you want a center of excellence. Because, I mean, that's natural that you want the best for yourself and for the patients. But in a situation where resources are limited and you have so many people to care for, now, how do we really do that? Right? Now, the next session, of course, is going to be devoted to public health interventions. But I see that on that panel, in the next session, there's no patient advocate there. There's no patient to represent the views. So I would like to ask you again now, remember, now, especially when you were younger, if you were in a rural area where there was no center of excellence, no secondary or tertiary hospital, would you welcome being seen by a community, some training in sickle cell, who had some places to make a diagnosis, you and your parent, sickle cell disease, and give
Okay. You're very correct, actually. I think being in the city gives us much advantage, and because we have access to clinics and access to Google's, develop a coping mechanism depending on where you are. If you know that there's a hospital, you go to the hospital. But if you're in the rural areas, you're just going to cope. Whether it's your grandmother's herbs that's going to take you through, it will take you through, yes, until that time. So it is quite a challenge. Like you said, resources are not enough. So I feel.
What's your name, sir? I'll go to Omary and then Leon. So this is what we're going to do. We'll have 4 questions and then we'll address them. Is that okay?
Okay, good morning once again. And just again, a reminder to our colleagues on packaging of the message that you are giving to us, policymakers. For example, Emmanuel, what you are talking, especially on the stroke vis-a-vis advantage of using hydroxyurea, or what's my brother Mbonea, when you say it so far. Yeah. Organ with the sickle cell. This kind of message need to be packed together. And then, for example, with that message, it means that hydroxyurea is a medicine which needed on emergency cases. It has one of the most medicine within our package. So just a reminder, we need to repackage well our messages. And with the pain management, I think we need to have this guide to guide our service provider. So mine is not a question, but rather reminding the team, once we conclude this session, must come up with a few to-do things which we take as a resolution, because this is very important session.
Thank you, sir. I think Ibrahima started out already in his last slide. Recommended for the way forward.
Thank you. I have 2 short comments. First, one concerned the involving of the patients in the research. I agree with Rimba. The patients have to be involved in the research, for example, by involving them in the ethical board when they have to decide what we can do, how many blood we can collect, and so on. It's very important to get the opinion from the patients. The second comment concerns the transition. Don't forget that most of the patients are living in rural areas where we have no specialists. We have no pediatricians. We have just a nurse. This nurse, she's able to see adult, grandmother, and children. So we need to focus education program on these nurses. It's the same thing in the urban areas. The first contact for the sickle cell patient is not a doctor. It's a nurse. And that nurse plays a very great role. And finally, at the end, the transition will also concern not only the patients, transitions concern also the doctors. We know that we have some pediatricians, they made the transition to the adult doctors. Now we need that the adult doctors will need to make the transition to the pediatricians.
Thank you. That is very interesting. I've never heard that before, but that's great. I have a number of questions online, so I'm going to have the last question here and then go back online. Is that okay? Just please limit to the questions. Oh, actually, I have you and I have a patient, because patients have a chance to ask a question, so I will give them.
Thank you. want to repeat what I probably said some years ago in such a forum, that unless we increase the visibility of the problem that we are talking about here to a much larger part of the population, we will not succeed. And many times, those who make us succeed or fail, they are not going to be the doctors or the nurses. I do recall the issue of HIV when there were no antiretrovirals, and when they came around, they were too expensive. It was the activists, the patients, who forced the companies who were making the drugs to bring down the price. There is no way the scientists or the doctors were going to be able to do that. Now, with regards to sickle cell disease, we have to do something similar. We have to increase the visibility of this condition, of this problem, to our communities, to our leaders, to our politicians, and to everybody who counts, to everybody who determines how the money is spent in a community. If we don't do that, we are not likely to succeed. And I would say that the politician must be shown that how do they get votes? By engaging themselves in programs addressing the problems of people with sickle cell disease.
Thank you, sir. Did you say your name is? Was it the one that was a VC before? Oh, okay, all right, fine, thank you. So David Rees, you had that question. Please think about how to respond in a way that the Lancet Commission can enable us to answer the question that Prof has asked. Have a patient to
Following Kim.
Hello.
Hello. Okay, speaking as a parent, I've been listening actually. The reason why I raised, there is a gap that we need to fill in. Gap that we need to think the
for you hydroxyurea and to know that it helps you, it does not need labs for me to know that your patient is progressing well on hydroxyurea. As you had previously from the presentation that was, we had that there was significant decrement of process crisis, acute chest, the blood transfusion. So that history that I will take from you, that from last year, I've never been transfused. And I see you are pink. You don't have any complaint at each clinic. I will know that the drug is working. So it doesn't need you to be in a very fancy hospital that it have everything. But how we interact and how I take my story, I will know your progress. Thank you.
Thank you. there were many issues that were raised. I think Prof. Chilolo did talk about education programs. And for sure, in my country, majority of children never see a doctor, let alone a pediatrician, specialist hematologist. When I went out to the outreach, I realized there were so many patients who still actually cannot access the second level hospital because of cost, transport issues, and they are there in the community. And I think it's a challenge for us, the researchers, to leave these centers of excellence and actually go into the community to do research there, to understand the community needs. And it is, I think the role of the community health worker is going to be quite key, and we need to involve them in training and for awareness, identifying. I think I already foresee with these spot diagnostic tests, they're already doing malaria tests in the community. I already see us engaging the community health workers to do some kind of testing for sickle cell disease and start the genetic counseling in the community. If we can get the specialists to be in the communities in Africa. And then we cannot overemphasize the role of patient involvement in advocacy to engage our policymakers to then make an investment to make a difference for the citizens in Africa. And to the mother, I know pediatricians, we love our patients, we love to hear the stories from the mothers, but I think physicians are very abrupt. They are busy people, they are overwhelmed with their lives. Or I'm not sure what, somebody has to do a research to start, because my patients cry when I tell them they are going to a clinic which is 50 meters from me. They will cry and beg to stay in our clinic. I'm not sure what's happening in the adult clinics. Maybe it's to do with communication. Maybe we communicate more. We are more empathetic, because adults are expected to be responsible for themselves. So I think that change is just too much. But we can learn from all the other programs that have transitioned patients from pediatrics to adulthood, so that we can use the same models, maybe having family centers that treat the people in one place. I don't know. And we want to give hope to mothers that when we come with the newborn screening programs, we would like the children to access care. And this care, we are going to push that it starts at the primary health centers. I'm so excited that the Sickle in Africa recommendations start at that level. So we've got somewhere to start from. Thank you.
Thank you very much. Thank you very much. I want to kind of just, I was actually right. Professor Balandya actually is the former VC, so I was right. And he also, I'm told that he's an advisor to the sickle cell program. So David Rees, we lost internet. I don't know whether you're back. If you are here, we are trying to see how we can actualize the recommendation from the Lancet Commission to move programs I mean, how we can benefit from that. How are you going to monitor the effect of the Lancet Commission? I'm going to, if you are here, you can comment, but I'm sorry, but I'm going to, Dr. Yaiza, I'm going to give you some few listen to respond as well. So you either start. David, are you there? Are you going to monitor the Lancet Commission? Okay, the microphone will go to Yaiza, and then if David is coming on, he can respond after that. How are we going to monitor to use that?
Hello, thank you. Yeah, so hopefully what we do with other commissions is that the authors will keep meeting over time, and then they will try to track the progress in the field by, I guess, doing a kind of, having a kind of systematic overview of what the different initiatives are doing, and then come back. You know, in the commission, we included a big table at the end that you can see. I think it's table 7, and they divided the recommendations in short-term and long-term goals. Obviously, it's quite ambitious because this is a global project, so it'll be taking a big time to collect information on you know, the different areas that we want to track. But I guess here for Africa, with the collaborators we have, and in India the same, and you know, we have authors spread throughout the world, so everyone will be contributing with the progress in the different regions. And the idea is to take that table 7 and then go back to each of the challenges and the recommendations they made in 3 years, 5 years, 10 years, on the time frame they have set, and then track the progress. So basically come back to the table and say, right, we recommended, ideally we would want, you know, hydroxyurea to everyone by this day. So then what have been accomplished? Have we sat at the table through the World Coalition, have any funding come in? What have been achieved? So I think normally that's the way, and then we will report back to you with another report and say what's been done. And I think it's equally valuable to report what hasn't been done, if it comes to that. And you can then try to hold people accountable, if, you know, if we can identify who. So, yeah.
Identifying who is a major problem. I mean, thank you very much, Dr. Isa. David, if you are here.
Yes, I'm here now.
Okay.
Yeah.
Yes, please. Can you just comment about how to make this work for us, and who to hold accountable, how we're going to get some feedback as to what is happening to this commission? You said it's a starting point, which you are right.
Yes, I think I heard what Ritah just said, and I agree with that. Really, I'm not really a politician or possibly the right person to comment on this. I think obviously it is a huge problem, and it's fine saying this is the starting point, but I think it requires lots of people to be persistent and not just write it and say, oh great, forget about it, but as Ritah said, to go back after 3 years and look at each individual point and to try and map progress against what we think should be happening, and to try and identify people who are responsible. But I think it's down to all of us who are interested in sickle cell disease to act on this, and to act at the political level as well as the clinical and the academic level. It's not a very good answer, but I think there's no. I think there's
very helpful, David.
There's no single thing. I think it is a collective responsibility for everyone.
Thank you, and I think the professionals and the activists, all of us are activists, to really use opportunity. Now, Tanzania have brought it closer to your government, and I presume that all countries, Francophone, Anglophone, should try and repeat to do something that actually will engage the politicians. I have a comment here, which says, from Becky, she says, maybe we should rethink the concept of comprehensive patient care and centers of excellence. Centers of excellence. Is it a building with everything, or should it just mean a facility that has different departments, not necessarily in one stop, but accessible to all patients with the capacity to manage patients with sickle cell disease? And I presume also thinking about, even if you have a center of excellence side, that's my comments, is that you can have, that can become a facility that allows a building, training, expertise support, but also should have a link in terms of a network of centers. Is there a connection And I had the experience of being to Zambia, and I realized that the primary care was connected to the secondary care and the tertiary care. And there are certain services that you have to deliver and the primary care. So I think there needs to be opportunity to network and make sure that the work in that center can be spread. But this is for upon comments, and I think Ibrahima, you started a comment about a comprehensive care and the centers of excellence, and then you want to comment briefly. Somebody else wants to comment about that, or the floor. So did you hear the question? Is it a building or is it people?
Yeah, yes, it is. The two. I think you have place to organize these activities, but you have to think the linkage which would be as we worked in this our framework. There would be a link between the top level and the primary health. Then there would be equity. Then when the person with the basic level knows that there is a control of what they are doing, and there is an exchange in the different level, there could be I don't know the word you can use.
Thank you.
This is what I think. I would like to profit of this to give a comment about the patient's questions, the parent's question about his child. I think we would include the question of therapeutic education in what we are doing. It is not only to give prescription of medicine. You need to communicate with patients and organize our activity to have therapeutic education. Everyone, parents or child or children would understand what it is the meaning of every act you are doing.
Thank you.
Thanks.
Thank you. Actually, I've realized time. So we just want to say, please, can we acknowledge and just give them a very round of applause, including the ones here and including the ones online. Thank you very much. And I'm going to hand over the phone to my chair. Thank you.
Thank you very much. A round of applause to Professor Inusa also for great chairing. So we've come to the end of the first session for day 2. We'll have a break. I think we have 50 minutes for breakfast and 50 for breakfast networking. We can also visit the poster room to look at posters. And then we'll convene at 11:30 a.m. sharp for the next session, which will be public health interventions on sickle cell disease. Thank you.
Out. This is actually a global map. We are now moving from, it's upside down because we want to really highlight Africa and the mortality rates of SCD in Africa. And I think for us to really hit sickle cell disease hard by moving from individual care to a public health intervention, which can really impact globally, we have to look at things from a different angle and really have to focus on Africa. So this panel, we have the pleasure of having very experienced and esteemed guests on the panel. We've got Dr. Omary Said, who's going to give up plenary. We've got Dr. Ntuli, who's an expert in finances. And we've got Dr. George, who is an expert in HIV and NCDs. We've got Dr. Lucrece Delicate, who he's really done phenomenal work in raising SCD awareness. We also have Dr. Obiageli Nonudu. Unfortunately, she might not be able to join, but we'll reach out to members of the team who work closely to her to maybe, fill in the gap while she's not present. So with this, I would like to invite our keynote, Dr. Omary, to give his presentation, and just to briefly give an introduction to Dr. Omary. He is a prominent policymaker for the Tanzania government, and he's really worked hard in Great. So we want to welcome to the podium, and he'll be talking about public health interventions for sickle cell disease very globally. Welcome, Dr. Omary.
Okay, good morning. As I've been introduced, my name is Omary Ubuguyu. I'm Assistant Director for Non-Communicable Disease from the Ministry of Health, but I'm not prominent. Yeah. I'm not sure if you can see me here because I'm vertically challenged. Okay, it's just a brief talk on public health intervention. I'm a student taking PhD on public health, but very junior student. So I know a little about public health, but I've been working in that area for quite some time. So probably I'll be using experience. So you'll forgive me, the public health specialists, if I don't represent you well. But colleagues like Ntuli and the others, I'm sure I'll be representing you well. So just very briefly, we'll talk about overview of sickle cell disease. Probably I may not talk much about that because for over the past 10 or 12 hours, we've been talking about the same. Especially on the magnitude of the problem. Many people know about that. And there are some few issues on public health perspective on the sickle cell, gaps, interventions, and the recommendations from our section. I think, Emmanuel, I can see some of the data from some of your publications, especially on Tanzanian data. We have seen that problem of sickle cells, especially for the newborn, it is around 1.2 on average, and 20%, around 20% for sickle cell trait in Tanzania. I think the rest have been communicated with the team. Is sickle cell a disease of public health problems? When you look at the number of people, especially newborn, with, for sure, you may say that it is not issue of public health problems when you have only 1%, one child out of 100, while we have so many other conditions for the newborn, you may know that problems. But when you project for those who have sickle cell, out of 100 child with a sickle cell, 90 die within their first 5 years, then for sure that is something for concern. Even if you are not a public health specialist, you know this is of concern. Out of 100 children born with sickle cell, 90 will not survive within 5 years. That is something we need to act on it. But one may wonder and ask, why are we not taking action yet? Because this is known, but it's very unfortunate. As I said earlier, our biggest challenge is we don't know how to pack our messages, and we do not know where to deliver those messages. Most cases, it remains within our publications, and it is within the groups, and it doesn't get out of the groups. So if it is something of a public concern, then we need to shout. But how are we going to shout? That is very challenging. We know 1 out of 5 Tanzanians have sickle cell trait, and Dr. Deo, my colleague, Soka, he has been on the ground in most cases talking about that, and he has a famous campaign at secondary schools talking about breaking the sickle cell cycle. It is tricky though, as we discussed yesterday and earlier today. We should communicate with the publics about the trait that we have and the preventive measure. That is very challenging. I had that photo, which is very famous, and I like to use it in most cases. When we had cleansing of albino in Tanzania, those people who are living with albinism, they had in big trouble. And this is almost in almost all African culture. It is taboo having somebody with albinism. And probably because we wrongly packaged our message to the community, and then people start acting negatively. So some few questions to ask, and probably we may discuss within our group. What should we tell the public? Who should do so? And how much of the information should be given for public consumption? And are we ready to bear consequences? And what are the mitigations when things get wrong? We know for sure on public health, we don't go into molecular level, and we don't go into a nitty-gritty, but rather we take a well-chewed information, and then we packaged it so that people in the parliament can understand and act upon. So the biggest problem is lack of awareness, especially to our policymakers. We will discuss later how best we can do that, especially when we want to meet the policymakers. We know with all those balls there, it is very difficult to pick a sickle cell. Most of us will go for the bigger black ball. And in Tanzania, especially for under 5, the black ball can either be malaria, tuberculosis, upper respiratory tract infection, something of nature, which catch the eyes of many, because when we go to most of our facility, we award or a dedicated wing for severe malnutrition. We meet those kind of children, and in most cases, people are moved or become emotional when you see those kids are suffering from malnutrition. Very few wards or places when you can see someone with sickle cell disease, probably because you can't point it, and probably they are among those with the malnutrition. So if you have a lot of issues to deal with, multiple agenda, then you have to be very rational when you select the interventions, when you find the package, how much are you going to to spend and where are you going to spend. So you need somebody who's a very strong message, who had well articulated information so that you can invest on those areas. Then the costs of interventions, and we have to declare that in most of our countries, I was very much tempted to talk about Africa, but I'm afraid that I'm not knowledgeable enough, so I'll confine to Tanzania. So you'll forgive me, other chaps from other countries, because I'm not confident talking about what is going on in your areas. So I'll confine myself to Tanzania. So Ntuli, you are a guru in finance, and probably when we come here and to discuss, you talk something on that. But for sure, in most of the African setting, we are very poor in financing strategy, especially for healthcare. We have resources sometimes, but we don't use them well. And our priorities sometimes diverge from the public health priority. And in most cases, it's confined with the needs of somebody who's spearheading the either the section or department or the ministry. Shortage of qualified staffs. For example, in Tanzania, as we speak, we have only 48% of healthcare workers as compared to what we were planning to have. So the shortage is critical in both quantity and quality. For the qualified staffs, I think the number is also very low. Infrastructure, we can talk much about that. We were discussing about Center for Excellence. We probably have none, but we have some centers which provide a comprehensive services. At PHC. I can bet out of 10,000 facility at PHC, less than 1% is offering sickle cell services as a standalone, or probably a well planned clinic, but rather we'll be treating them episodically when somebody goes to pediatric. So there's no infrastructure to cater for sickle cell patients. And again, poor access to medication, as some of the colleagues narrated earlier. So when we talk of awareness creation, this is key. In most cases, we depend on you scientists, researchers, clinicians to tell us about data, the clinical information, something which is very rational, and then we can make a decision out of those. But that comes to us as directors, assistant directors, program managers. That is something that we can take to make politicians act, especially our budget is addressed at the Ministry of Health, but it is concluded at the parliamentary session, where probably 99.9% are non-medics, and they know nothing about disease. They only know patients within their family or somebody they encounter along the way. So they don't have those global picture. So we need people like Rafa and other colleagues to speak about the disease, about the interventions, and probably where to invest, because emotionally they are moved on that. In Tanzania, we invest a lot on commemoration days. So we have Sickle Cell Awareness Month in September. We are working very hard during September and June when we have a World Sickle Cell Day. But the remaining 10 months, we keep quiet and there is no much activities on the ground, and people tend to forget. But luckily, in June, it's probably closer to our budgetary session at the parliaments. So probably some of the policymakers are motivated and probably they may invest. It is very key to understand that advocacy has many faces, and this is very important. Dr. Stella, what you and your colleagues did the other time was just a very simple act of transplant, but the impact from what you did on those days when you welcome Honorable Prime Minister changed the sickle cell intervention in the country. Immediately, I can tell you, immediately after this, we received a letter from the Prime Minister himself, and he asked us to sit down and see how we can have an action plan on newborn screening, treatment, and probably see how best we can do on treatment. That was the impact of this single act of welcoming Prime Minister to inaugurate the intervention. So sometimes, if you know well how to do it, then it is very easy on the public perspectives. On the very same week, we had World Sickle Cell Day, and Honorable Minister also attended. Dr. Lulu Chilande, Soka, they were there, and Dr. Mashungi, and they could see how our Honorable Minister reacted on that day. And it was a little bit hard to us because they were pointing finger on us. Why this is not happening now? So everything was here and now. From World Sickle Cell Day and that inauguration of bone marrow transplant, few things happened. We were asked, of course, to prepare some action plan, especially to ask for addendum on our budget. And Honorable Minister had a conversation with Excellence President Samia Suluhu Hassan, and she was ready to donate all of those amount of money for the advanced therapy. It was not confined to sickle cell, but a good chunk of it will go to the sickle cell. But probably, I'm sure, Stella and colleagues, we won't be able to consume all of those amount of money, because in a government budget, it is not like a grant you are given for 5 years. This is for 12 months. So within 12 months, you have to spend it. You don't spend it, then next year they will say that we are giving you too much because you are not able to consume even 60% of it. So why can't we cut it down to 2 billions, which you can consume? So let us work together and see how best we can utilize the resources that we are allocated. I'm sure it is not 100% for the sickle cell, but a good chunk will go into sickle cell if we plan it well. Again, we had a discussion with Arafa, Professor Kamuhabwa, Professor Balandya on the same week or just a week prior. And we were discussing about having hydroxyurea in Tanzania, citing some of the example when the MUHAS were able to produce locally hydroxyurea. And it was quite substantive because it cut cost for almost 70% from the routine cost. But we know for sure if we go to a bigger number of clients who demand it, the local production may be overwhelmed, and probably we may need other colleagues to team up. I know we have colleagues from Novartis. We are working very close in this area, and other chaps in this room who are working on this area probably may think of collaborating on that area, because in most cases we are buying a medication from India and other parts of the world, which is become a bit expensive because of cost of transportation and other production costs. which is quite different from Africa, where cost of production is relatively low compared to the rest of the world. Again, we are asked to act, especially on see how best we can procure point of care testing, because as we spoke earlier, that with a critical shortage of staffs, and only point of care tests could be a game. The rest, I doubt if we will be able to do so. So on the identification and enrollment to care, with these, I think I preempted myself yesterday when I was commenting on it, and that is my opinion. But at the country, we have our stand, and our plan is to have universal newborn screening. That is a plan. Again, when we did some calculation, Lulu, we were there with Honorable Minister. And actually, it wasn't me. It was Lulu who was presenting to Honorable Minister. So we had some calculation, and it looks that with this budget, it is quite difficult, but it is not impossible. When we had a discussion with Dr. Ntuli, in most cases, we think of having at least a 5 years projection with that. But when we have some discussion and during the conclusion of this symposium, could probably set a target like what they are doing on HIV. Our National AIDS Control Program, whenever they report, people never ask them how many people do you see, how many you dispense medication. The question is, did you meet the first 90, second 90? What about the third 90? So it is quite very clear. They are supposed to meet 90, 90, 90. So with the sickle cells, we are asking for numbers, and whatever that we are reporting here may not be enough. We say that we used to screen 1,000 children last year, and this year we've reached 10,000. It is quite significant, from 1,000 to 10,000. But when you compare to 2.5 to 2.4 million children, it is just a peanut. So if we have similar targets, not necessarily at this particular time to reach 90, even 20 is something. So with these brains around, we can think, what targets do we want? We shall on treatment, and those probably you can say those who have been stable or maintained on treatment. So early diagnosis and newborn, these are something that we can think of. For example, if we wanted to start this year, we expect to have 2.4 million children, but most of our under 5 are not yet screened. So in the next 5 years, we are talking of almost 10 million under 5s who needs to be screened. So that's why I said earlier that we need to be realistic and see where are we going to invest. 4 million newborn. We're talking of around 10 or 12 million under 5s who needs the screening and to be into care. So these are kind of the issues that we may need to think of. And when we think of the home grounds solutions, just to have standard algorithm, probably we may not miss someone. We have mapped, we can start with the mapping and then scale up. Always we start with the high risk groups. I'm a psychiatrist by professional, and when we were doing some HIV interventions, we identified the high risk groups. So female sex workers, where people who injected drugs, we identified within HIV portfolio, and we were targeting them very specific because we know for sure if we hit it hard, then the HIV prevalence will go down. And this is what happened on the ground at the moment. So with the sickle cell team, again, we have to pinpoint where do we want to start and then scale up from the hotspot. Use of point of care tests, as I said earlier, probably is very promising because you don't need experts, you don't need electricity, and you don't need complex procedures. And this can be done even by outreach workers. And we have not yet reached 100% of children born in the hospital. Their traditional birth attendants also are taking care of our pregnant women. So point of care tests probably could be the game changer in our setting. So the likes of Novartis, I don't recognize the other company here. Sorry, I'll keep on repeating, mentioning your company. I'm so sorry for that. We could probably team up. On one hand, you are supporting us, but on the other hand, you are doing business in this. So we can strike a deal. If we increase the volume, could probably lower the cost. And that is win-win. We can have courage to go deeper into the field because we know we have some philanthropies, we have some companies that has agreed or accepted to support us in this area. I will not talk about the access, probably, especially on the basic care, because most cases it has been presented, overly presented in our presentations. For availability for hydroxyurea, we have been. Astelia, are you in the room? Yeah, could probably be very mean not to mention your name. We have Astelia on the ground. She has been working with us on sickle cell because she's a coordinator. She's the coordinator, and she was the one behind establishment of hydroxyurea, especially under NHIF, because we were pushing a lot to talk to our NHIF colleagues. But unfortunately, as colleague said earlier, there are some challenges with our health insurance scheme because we were targeting to have universal health insurance, and unfortunately, the parliament didn't pass the bill. So there are some chaos on that area, but we are working on that. For the bone marrow transplant, we have started it almost 12 or 15 months ago. That was autologous bone marrow transplant at Muhimbili. Very few people had access to that. Now we started another one, allogeneic at Benjamin Mkapa. The challenge of excellence is the cost. When we give them seed money, they can start 10, 100 patients, but for the routine care, the facility, they need to have operational costs, which is a bit expensive. And in most cases, these kind of innovation slow down pay for it, because for us, we just write a letter to Stella and the colleagues, tell them that you just exempt them. But next year, they fail to have an operational cost, which become a cumbersome. I will stop with these slides, but one thing that I want to show you, THC is a game changer. We are talking of Center of Excellence and so many issues that we are talking about. But for example, in Tanzania, 99% of our facilities are at PHC. So the Center for Excellence, we only cater for the remaining 1%. And very few people get access to those kind of facilities. Many will die or will succumb because they didn't reach to the peak. Use of peer, this is a cornerstone, especially when we want to do issue related to promotion and the awareness on preventive aspect. When you're RAFA, tell the public that it is better to know your sickle status, and then you can make wise decision. Those audiences will understand from ARAFA. But when Professor Julie McCartney talk to public and tell them that you need to know your status and make decision, then the public will interpret that this is something very dangerous, and doctors warned us about this, and probably it is very delicate and risky. So when we are doing promotion, please let us use the peer, easily deliver those messages without those risk of stigma and abuse. So thank you very much.
Great. Thank you very much to Dr. Omary Ubuguyu, who is the Director of Curative Services, a very high profile director, and also he's a psychiatrist, and he's had a lot of academic experience, as you can see from his presentation, which was very well laid out. Thank you once again. So I will call upon the panelists to come up, and I will introduce them, and they can say briefly just in their line of expertise before we open up the floor for discussion. And as they come up, I'll just give a few summaries from some of the points that Dr. Omary raised up. So I think it was fantastic. Thank you. And one of the key points was advocacy has many faces. We had the faces of Julie McCartney, a researcher. We had faces of a patient, really raising advocacy, lowering costs. I think I'll leave that to Dr. Ntuli to address. And I think plans without targets, right? Or visions without targets are also not very useful. And I think Dr. Omary really stressed the need to have targets, to have plans, how and what do we want to achieve. So I'll hand over to Dr. Ntuli to give us a few words. Dr. Ntuli is a medical doctor, and he's really dedicated his career to sustainable health financing and strengthening maternal and newborn health in resource-limited settings. Since 2017, he has held the position of Director of Health, Social Welfare and Nutrition Services at the President's Office, Regional Administration and Local Government Authorities. Welcome, Dr. Ntuli.
Thank you very much. And I must take this opportunity to first and foremost to register my sincere thanks to the organizers of this very important meeting, and also to the champions, including my colleague, Professor Balandya, Professor Julie McCartney, and the sickle cell community. A bit of context. So in Tanzania, we've got a unique arrangement. In some other countries, you have the Minister of Health responsible with both the tertiary, secondary. We've got a bit of unique arrangement. It's similar to that of Nigeria. So we have the President's Office. We mainly responsible with the overseeing policy guideline implementation at the primary healthcare level. And we have in total of 6,600 primary healthcare facilities in the country, but we also oversee the community healthcare system. And the community healthcare system is composed of the Health Facility Governing Committee, all the governance structures, as well as the community healthcare workers. And I'm very much delighted to be part of this important meeting. As far as the primary healthcare financing is concerned in this country, we have an array of sources of finances, ranging from the user fees, which is having about 42%. We have the National Health Insurance Fund. We have community healthcare fund. We have the Health Basket Fund. Under the Healthcare Basket Fund, we have about 6 countries putting together funds in one basket to finance the primary healthcare. And 90% of those funds goes to the primary healthcare. And also we have grants from the government of Tanzania, as well as the receipts in kind. As Omary said, this year, in January, when our bill for universal insurance didn't pass, but it's a work in progress. We are working with different ministries, trying to revive the bill by accommodating the comments which were presented by the members of the parliament. In terms of resource allocations, we use a formula, and this formula have number of factors. One of the factors which is included in the formula is the population size. And also we have the poverty index of particular district council. And then also we have the under 5 mortality, as well as the land cap factor. So for the past 5.5 years, the Tanzanian government have had a number of reforms, particularly at the financing. And one of the notable reforms is the introduction of the direct test facility financing. Initially, funds were dispersed up to the district level, but later, following a number of studies which were conducted by the World Bank and local researchers, we decided now to move from dispersing funds from the district level to the primary health care facilities. That's a huge reform, and it is one of its kind in the region, and we are very happy with that one. Because one of the things which pushed us to go into that reform was delays in disbursement of funds to go to the lower healthcare facility level. But the second one was misappropriation of funds at the district level. But with this new arrangement now, there's more autonomy to the frontline healthcare workers in terms of planning and budgeting. Now our colleagues who are working at the primary healthcare facility level, they can plan on their own, they can implement the plan, and also they can evaluate themselves. This is something which was next to impossible 5 years back. So with sickle cell disease now, this offers a huge opportunity because what we need now is to make sure that this message goes down to the primary healthcare facilities. And we are the ones to actually trickle down that message to our colleagues who are dealing with the plans and budgeting at the primary healthcare facility level. So maybe one of our take-home assignment here, I with Omary Ubuguyu, to be to inform our colleagues who are working at the primary healthcare facility level what they are supposed to do, because our planning and budgeting cycle begins in October every year. So we will send some directives on how they can allocate funds to make a sickle cell disease getting the adequate fund for screening. Because listening from the presentation which we had yesterday and also recommendation from the Lancet Commission, it is quite clear that we need to start with identification. The planning and budgeting process, you must know the magnitude of the challenge which you have at hand so that you can decide how much should go for that. So I think one of the things which we need to do now is to make sure that we allocate some resources for screening, especially for the newborn and early infants. And I'll a bit deeper with Omary. I think we will try for this year because our budget cycle began in October, and see next year if we were able to meet the 2.5 million deliveries in the country. I think it's doable, and I'm glad that the composition of the people who are participating in this meeting are from the scientific community, the researchers, we have the manufacturers. So we can have a deal here that, look, we wish to go for universal screening, newborn screening in the country. So can you subsidize? Because our wish is there. So I think we need to engage in this type of conversations because we are the ones who want to make this happen. But as for the government of Tanzania, we are more than ready, particularly for primary health care, which constitute about 99% of all healthcare facilities in the country. We will start this one. We will need our colleagues at the Muhimbili University, the patients associations, and of course, the non-state actors to work with us so that we can test if that is feasible. So that's one. Secondly, I think it's quite high time for us to try to exploit what we have. With 600 primary healthcare facilities in the country and more than 7,000 outreach and mobile sites, this is a great opportunity for us because in these outreach and mobile sites where we provide immunization and vaccination activities. So we can use those platforms as the area for integration. So this is something which we can start it right away, including the issue of point of care testing. For us, that shouldn't be the challenge because the machinery is already there. But all what we need, and that should be part of our take-home assignment. How do we engage the manufacturers so that they can reduce the cost for the testing devices, including the Sickle scans, and also the issue of hydroxyureas. For us, the machinery to take these commodities down to the primary health care is there. We have the medical stores department in the country, which is mandated with procurement, storage, and distribution of health commodities, including the sickle cell commodities. So that's not a challenge. If you go to some other countries, they are facing that challenge. But in Tanzania, we have a very reliable system for delivering the health commodities. So we can agree here and say, okay, part of this one, maybe Novartis and some other partners who are part of this conversation, see how best they can do that. But that doesn't undermine the role of having the local manufacturing initiative. We need that one. But in the meantime, let us also try some other approaches. The other thing which I thought I should speak about is trying to engage the politicians. I've been part of the people who tried to start 2 caucuses for members of parliament. One of the caucuses which we started was on nutrition, parliamentary caucus, and the other one, social affair parliamentary caucus. Let us try now to go with the sickle cell parliamentary caucus. This is doable, and I know how to go about. So I think, and this is to allude to what Professor Balandya said, let us not just work on our own. We need to engage the politicians. I and Omary, we are working with politicians on our daily activities, but having members of parliament speaking on our behalf, this will help a lot in pushing the sickle cell agenda down to the community level. The last thing which I thought we should also start thinking, no, we have done a number of research. We have abundance of knowledge about sickle cell. Now we need to move from a bit of molecular going into the public health approach of the sickle cell. It's quite very important, but doesn't mean that we need to stop, no. But now it's a high time. How do we deal with implementation science? Under the implementation science, how do we deal with the issue of feasibility? For instance, Tanzania is a huge country with size of 1 million square kilometers. So we need to find out different approaches to reach out to different populations so that the sickle cell message can be heard and understood, and those can be implemented. So implementation science, the issue of feasibility, scalability, the issue of sustainability, these are quite very key because the knowledge we have already, we know what works, what doesn't work. So all what we need is to scale up these interventions. We have the Pen Plus doing some supporting us in one of the districts in Dodoma. That's not enough. We have 184 district councils across the country. The population of 1.7 million people. So we need to find a way how best we can reach out to all the people in need. Otherwise, I think other things will contribute while we are having some Q&A. Thank you very much.
Fantastic. Thank you very much. Multiple sources of funding, move from basic research to implementation science, a lot of take-home points there. So I think we'll move on to Dr. George, who is the Southern Africa Regional Advisor for non-communicable NCDs at the Center for Integration Science in Global Equity, Pen Plus Mozambique. And he's got a vast number of experience in HIV implementation and prevention of mother-to-child transmission, as well as NCDs such as breast cancer, cervical cancer, hypertension, diabetes, and so on. Welcome, Dr. George.
Thank you very much, Victoria. So I'm not happy not seeing colleagues from Angola in this room. So we need to think a little bit about the Portuguese language also. I'd like to emphasize about that. So I'm coming from Maputo, Mozambique. So I would like to talk about the shortage of qualified staff as a bottleneck for public health intervention, as Dr. Omar said. So we are working under the Penny Plus approach, and we are not working with only one disease. We've got a package of like sickle cell disease, type 1 diabetes, asthma, and rheumatic heart. So with this approach, we train the health workers. There is no doctors on the communities. We are working with the nurses and the clinical officers. We design some and adapt some tools like guidelines from the Penny Plus network and our specialist based in Maputo. We are designing a register system to monitor the information and compare. And we provide some tool to make a diagnosis of this complex disease, like ultrasonography or echography, sickle scan. We just started in these 2-3 weeks, and glycemia study. Very simple things. So what we have learned after 6 months after we established this first Penny Plus clinic, we've got 3 patients suffering from rheumatic heart disease. I think it was unthinkable to have this diagnosis in those rural, very rural areas. We've got 9 patients suffering from type 1 diabetes that are controlled. So many patients type 2 diabetes and the asthma. As I said, so we think screening the patient on a sickle cell. I think just to summarize, we have to work on those conditions that we are with the resources that are available. Thank you very much.
Fantastic. Thank you so much, Dr. George. I think we will call upon Dr. Guilherme Queiroz at some point to also strengthen the Portuguese presence and voice in the room. Great, thank you so much. Great, we'll move on to Dr. Lucrece. She has a PhD in chemical and biological sciences. And one of the most prominent is that she's a founding president of an NGO for sickle cell disease in Gabon. And she has done tremendous amount of work and research in hemoglobinopathies, and of note is raising awareness amongst patients in SCD related.
Thank you, Victoria. Hello, everyone. I'm happy to be here, and thank you to Lancet Commission to organize and MUHAS to inviting us in your beautiful country. I'm a French people. My apologies for my English. I will try to speak in English, but I'm French people. Okay. When I obtained my PhD in Paris, first thing I knew sickle cell disease like something in books, explanation, scientific explanation, everything we know about sickle cell disease and genetics, because I'm a geneticist. And when I go to my country, Gabon, I just see another definition of sickle cell disease. Sickle cell disease is like for me a winch, divorce, something can define like a family division. I don't know in English is this correct, but it's like something wrong in the family. And when I saw for the first time a true sickle patient, I'm a searcher, I'm in the lab. And first time I go outside to see other things in sickle cell, scientific sickle cell, I saw this little boy, he say, hello, mom. And can I speak to you, mom? I say, yes. And say, I need your help. I need your help. I'm very tired. And I asked to a pediatrician, who is it? He say he's a little Mabika, his name, Mabika, is sickle cell patient and he have HIV. And just this guy looked like someone who is lost, need hope, need everything. And I just say, what can I do for you? He just say, help me. I say, how? I don't know how can I help you. And just 1 hour after he's died. And I just stay in hospital and I go to the lab and I take my chair and say, I must do something to these children, sickle cell patients for Gabon. And what can I do it? And in 2018, I founded and create a sickle cell organization of Gabon for help every children who need help of pediatrician or researcher or mom or everyone who have a love to another one. And sickle cell organization of Gabon have a main goal is to information, education, and help to a research. And our principal activity is to go to whole community, a rural community, to explain what is a sickle cell disease, do a genetic counseling, and explain to parents and patients that sickle cell is not a story like a winch, or like they say it's a snake who is hit me, who is I don't know in English how to say, and they say just sickle cell is not a genetic disease, is a winch disease. And when you say you need to take your acid folic, your drugs, they say no, it's not, no need. I have my tea for my grandmother. I have tea. It's okay. No need to have a white drug. They say white drug. And just is this morning I heard this girl to speak with what is the role of pediatrician or practitioner which receive a sickle cell patient. Last week, I was in the Port-Gentil, is a province of Gabon, and I saw a little boy also, and his sister Morgan and Brel. Brel say, "Hi, doctor." I say, "Hi." He say, you are a smiling doctor." Yes, it is a problem. Yes, because they say when I go to the hospital, in general hospital, they say, you again. We are tired to see you every time. He's a pediatrician. We say to patient, "I'm tired to see you every time." And he say, "You are a smiling doctor." It's the first time I see the smiling doctor in my life. I just, wow. I don't have words to to speak for these little children of 12 old. And his sister say, "Doctor, I say, take your drugs because it's important for you." She say, "No, I refuse." I say, "Why?" "Because my doctor say, in French, in English, you die. Even you take your drug, you will die. It's not necessary. Don't come here every time to take your drug. I'm very tired." And she said, "I decide to no drug in my life. I refuse to take it." And I take half an hour to explain and speak with her and explain that the drug is important, why it's important. When you say just the word sickle cell disease, he just cry. "Why are you crying?" "Because I'm afraid I will die tomorrow." And I say, "No, will not die. Just take your drug." And I give her a acid folic, Acfol. In English, no? Yes, Acfol. Okay, medication. And she take it in her hand, and she look at me and say, "I will take it just for you. I will take it just for you." And I say, "This is my call number. You can call me every time, every day if you want to speak, but promise that you will take your medicine every day." She said, "Just for you, I will do it." And her mother said that the last time she take her medicine was when she had 6 years, and now she have 17 years. Donc this 12 years, like that. Donc patients need to have a smiling practitioner, a love practitioner. Drug is not sufficient. In our strategy, we have to transmit too much love to patients and add it to our formation of practitioners who will make something new. And for all activity, another activity we do in our NGO is research on the malaria, sickle cell disease, correlation, everything, thalassemia, and social and economic researcher in sickle cell to know about the impact of sickle cell disease in economy in the house of Gabonese population in the work and everything interdisciplinary discipline we have interacts in sickle cell. And we have innovating initiative, which is Ritah Dream. Ritah Dream is like realization of the best dream of the sickle patients. We have sickle patients who want to be biologists or pilots or architects or everything you want to. And when you do the last week, we do the last dream was architect. And we came with this little boy, Aziriel. Aziriel go to the Gabonese Association of Architecture. And it is just say, well, I really want to be an architect. You don't know his impact of in the mean of these children. They think that I can live, I can go, and I can try to work. I will be someone. I will be an architect. I will be an biology. I can enjoy my life. As a researcher, teacher, I want to be also love for sickle cell patients. Thank you.
Fantastic viewpoint from Dr. Lacris, and I think it's really important, possibly for this symposium, to reflect on. We've been drumming about access to drugs, access to medication, but even if the patients were to get them, what are the other challenges that are there for them actually taking those drugs? As you heard from Dr. Lacris, it's about the health worker to patient engagement. It's about other conflicting beliefs. How do we address them in a respectful way when you've got other beliefs that are coming in, which you need to address in a respectful way to encourage the patients to take their medication. And the Draper Dream, I think it was Professor Kisali who mentioned in the previous section that unless we increase the visibility of the SCD challenges to a wider community and stakeholders and leaders and politicians, we're really not doing anything. And I think in this session, we've begun to see some of the stakeholders we should be looking at. High school kids, allowing them to dream, healthcare workers. So I think we'll open up the floor for discussions and comments. A lot has come out of this session, and it would be really great to hear what the audiences have to say and input about some of the challenges that have been laid out and possibly solutions that are sustainable. Great. So I'm not sure if great, Prof.
We want to thank for site, for their passion, for when they done a recent assessment of the implementation of the recommendations, many of the countries are falling short. And we really need to emphasize this over and over again and probably make new recommendations. So I really want to know from Dr. Omary, thank you for the way you outlined the program in Tanzania, but I want to really know what is the constitution of your PHC? What kind of staffing, what cadres of staff do you have at different levels? Now, what is the lowest level? What is your referral level? And if you are going to integrate sickle cell disease into these programs, at what level would you recommend? And how would you recommend that we go about it? Do we limit it to, well, like Colin said yesterday, how low can we go? Do we limit it to doctors, nurses, or community health workers who can be trained to deliver some of the care? Thank you.
I was pushing ball to Dr. Ntuli, but he wanted me to start first. In our level, we have 3 levels of care. We have primary healthcare level, we have secondary and tertiary. At the tertiary level, we have National Hospital, which is Mbili. We have Zonal Hospital, because Tanzania, geographically, we have 26 regions in mainland Tanzania and 5 in Zanzibar. Ministry of Health caters for mainland, and we have Ministry of Health in Zanzibar side. So on mainland side, we have divided Tanzania into 7 zones, and in each zone there are 2 or 3 regions. So after National Hospital, we have zonal facilities within the 7 health zones that we are working. That is tertiary level. And so again, after a zonal facility, we have first specialized facility like Cancer Institute, we have Cardiac Institute, we have Orthopedic Institute, we have Mental Health Institute. These are specialized facilities, also at tertiary level. Here, there's specialists and super specialists in different cadres that are serving, that are primarily healthcare services that are provided. Primarily, we are providing specialized facility, and there is an epitome of referral within the region. Down from the tertiary facility, we have regional referral hospitals. In all 26 regions, we have these regional facilities, except in Dar es Salaam, where we have 3 regional hospitals, because almost 10% of our population is in Dar es Salaam. It is around 6 million people in this region. So we have 3 regional facilities in Dar es Salaam. At regional healthcare facilities, we have specialists, and we have 8 cadres offering specialized care at this region, and mainly pediatricians, physicians, we have obstetricians, we have surgeons, that kind of cadre. And below that, we have district hospital, and from the district down, this is where we have our primary health care level. At the district hospital, Dr. Ntuli tell you more about that. But generally, Ntuli, you talk about it. But generally, for the sickle cell services, we are thinking of having a comprehensive care and probably Center for Excellence. This we've been talking with Professor Balandya, Professor Julie Makani, and we think nowhere else than Muhimbili, where we can have a Center for Excellence for the sickle cell and hematology care, because we have a lot of people with hemophilia, thalassemia, and such kind of conditions. So Center for Excellence. And then we could have a comprehensive care at a zonal and specialized facilities, because we know they can offer a comprehensive care. All advanced therapy can be provided anywhere within these 7 zones, except for the highly specialized, like a bone marrow transplant, which is not possible to have in all other regions. And down from the donor facilities, just basic care should be provided. And it is just 12 months ago, we had a training for all healthcare workers in 700 health centers in the country. And we give them basic training on non-communicable diseases. It is just an introductory part. They can give basic interventions on diabetes, on hypertension, mental health, sickle cells, and all other conditions. So only basic care will be provided at primary health care level. Clinicians and nurses. So we had 2 sets, 2 clinicians. This is assistant medical officers and medical doctors, and with nurses on the other groups. So it is just MD if they are available, but they are not many. So in most cases, we had people who had a diploma on clinical medicine. And we have nurses who have either certificate or diploma in nursing.
Thank you very much, Omary, and thank you very much, Professor Dekile. That's a great question. So our primary care has 4 levels. So we have at the base of our primary care, we have the community, where we have the community healthcare workers. They are mainly responsible with health promotion activities, sensitization, and also they do accompany those who are working at the dispensary level, health center, and district level to go for outreach services, as well as mobile services. So whenever there is a campaign, or nurse distribution campaign, or immunization campaign, the community healthcare workers are working alongside with those who are working at the dispensary level. And our dispensary level, or dispensary facility, mainly provides the outpatient services and also preventive services. But as you go up to the health center, it's where we have outpatient services as well as the inpatient services with some selected surgical services and some diagnostics, including the X-rays, ultrasound. So are provided at the health center level. So since 2015, we did also decentralize the human resource for health. Initially, these health centers were manned by the clinical officers who are diploma holders and the clinical assistants who are certificate holders. But as I'm speaking to you now, we have the medical officers working at the health center level. Yes, yeah. So we have also decentralized because we do provide the surgical services at the health centers level. So as per district hospital, we have inpatient, outpatient, array of diagnostics together with some specialized services. So for the past 2 years, we have started introducing some specialized services, including pediatrics, OBGYN, are also manned at this level. So with regard to sickle cell services, we need to structure. And that's why I was very happy with the presentation which we had yesterday from Penn, where we found that they have identified one district council in Dodoma, and which is working with one zonal referral hospital. So we need to strengthen the referral system where the primary healthcare facilities, they should be able to refer the patients to the regional referral hospital or zonal hospital. And some of these services, especially advanced therapies, I think this should be for the district hospitals, regional referral hospitals, and what have you. And including even the hydroxyureas. But I was talking to Professor Balandya that there are some policies which you offer hydroxyurea at the level which doesn't cause some toxicity. But I believe that the health center, the district hospitals, and regional referral hospitals should be the one to offer that, because they have a bit of established laboratories as compared to the dispensary. I'll advocate dispensaries to offer universal screening for the newborn, because mothers are delivering at the dispensary level. And this is also an anchoring site for the community healthcare workers. Whenever the community healthcare workers conduct the activities at the community level, they do submit reports to the dispensaries, health centers, and the district hospital. So this is how we work at the lower level, and this is the working relationship between one level to the other level. And for us, in the meantime, we are trying to formalize the community healthcare worker cadre, whereby they're supposed to attend 1 year course, and they'll be taught about 6 modules. One of the modules to be taught is on non-communicable diseases, including the sickle cell.
Great, thank you very much. It seems there's another question from, okay, we'll take 2 from the back and then we'll go to the comments in, okay, we'll take the 3, 1, 2, 3. Yeah, we can start it. Yeah.
Thank you very much, all the presenters. I just have a follow-up question from Dr. Ntuli. So these community health as primary health care, how does it work in big cities like Dar es Salaam? Do we have the same infrastructure or how?
So let's take the 3 questions and then we can give the panelists time to respond.
Thank you very much. My question has 2 parts. Part 1 is about premarital screening in sickle cell disease, and the other one is on the infant screening. First of all, I should say I'm very delighted to have 2 very important people as panelists, Dr. Omary and Dr. Ubuguyu, because these are very key decision makers for the, in the health sector in this country. Dr. Omary has been speaking about the issue of stigma in premarital counseling. But I'm a champion of premarital counseling because I believe for low-income countries, primary prevention is paramount, not only in the area of sickle cell, but almost all diseases. Primary prevention is the way to go. And when it comes to sickle cell disease, primary is paramount. Now, stigma in sickle cell has always been there, regardless of premarital or postmarital. Stigma is one of the issues that we've been addressing sickle cell disease since we started advocating for this disease. So we shouldn't hesitate going for what is the lowest laying fruit in terms of intervention because of stigma. Because what is the opposite of stigma? When we go away from premarital counseling, what do we expect? We expect stroke, we expect failure, we expect priapism, we expect deaths. You presented there that 90 out of 100 children who are born with sickle cell perish before the age of 5. Now, how are we going to lower these numbers? We must be very focused on primary prevention because of the nature of the resources that we have. And fortunately for this country, we've done a great work in that area. And it's, again, very fortunate because Dr. Ntuli was the person who blew the first whistle to start a pilot on premarital counseling among students in this country. And we did a pilot for 2 years, and we screened more than 10,000 Tanzanian students, both from universities, colleges, and secondary schools. And we have a comprehensive report on that, which again was disseminated to all important stakeholders last year at Ntuli's ministry. And the person who was the guest of honor for that is now the sitting deputy PS for Ministry of Health. So this thing is known, and we know the pros of premarital counseling. The best entry point for premarital counseling is at school points, secondary school entry, high school entry, and college and university entry points. These are the best points to screen our youths to know their status, and then we empower them to make the decision, wise decision about sickle cell disease. By so doing, we can reduce the burden of sickle cell disease in this country. So, what's the action plan? All we need is a circular for that. All that we need is a circular for that, because I know lots of people can afford to screen. Gone is the era when screening for sickle cell used to cost more than $90. Now you can screen for the cost of $5 to $7. So at the end point, every student is supposed to bring a medical report. What's the issue? What's the point of doing a full blood picture to someone who is going to high school? I'd rather screen for sickle cell, for sickle gene, which will make a lot of sense to this person than doing UPT, urinalysis, full blood picture. These are the things we need to change. So I'm calling upon you, my leaders, let us have a circular on that so that we start implementing this thing. We start now. This is the time to start. We have the system in place. We have more than 2 million youths who are in school, and we can work hand in hand with the Ministry of Education to address this matter. That's number one. Number two.
Great. I think we will give other speakers a chance and then we can take another round.
All right.
Is that okay? Thank you so much. Very powerful contribution advocating for upscaling of screening for young adults. Thank you.
Hello, everyone. Thank you for the chance to speak. My name is Guilherme Queiroz. I came from Portugal and I come to represent the DREPA Comunidade. There is a multinational platform, there is community centered and community driven to improve knowledge and care about sickle cell, around sickle cell disease in Portuguese speaking communities and countries. It's great to see Dr. Jorge from Mozambique also representing our community of Portuguese speaking countries and people around sickle cell disease. We started as a platform with meetings with various associations from these countries. And it was great to see Dr. Nodu speaking about this chance of sharing experiences between patients and relatives. I remember one meeting where there was almost a competition to say who was older between the patients, like I'm 67, no, I'm 70. And then like the patients and the relatives were really, really happy they had children and didn't know what future was expecting them. And seeing those experiences of other people from other countries in the same situation is really, really grateful. And I think these coalitions are really, really important. I want to talk also about community in this sense, because an interesting reflex of the historical negligency about sickle cell disease is the strength of the community. Now, communities had to organize themselves in order to overpass the invisibility that was imposed by the state and by the institutions. And these communities must be listened now that the awareness is raising and everyone is more or less speaking about sickle cell disease, because they have a lot of knowledge that is important to the activities, to the intervention that we are planning for. And I think to maintain and to keep this active voice of the communities, of the relatives and of the patients is really, really important. Sickle cell disease is not a new thing. We didn't discover it this year or 2 years ago when the commission was launched. It has been here for decades and centuries. And I think this knowledge among the communities around sickle cell disease has to be heard and has to be complemented with public health intervention that we are planning to do. And this is important because one epidemiological data that I think, and us in DREPA Comunidade are trying to enforce, is precisely education and knowledge. And it's not something that is expensive to do in epidemiological studies, to add a questionnaire asking people that we are screening or that we are testing, what is the name, for example, for sickle cell disease? Because we are saying sickle cell disease, but in some countries, for example, we were working in São Tomé, and people were speaking about bone disease. So maybe there are other names, maybe there are other forms of seeing the disease that are important when we want to implement public health interventions. Like, what are the symptoms that are associated with it? And I think education and knowledge must be assessed. So when we implement and intervene, we know what are we doing and with which people and what knowledge are we working with. And education must also come with newborn screening. So I don't think newborn screenings should be a public intervention per se. I don't think we can implement newborn screening without the whole package, because it is not that useful to diagnose 40,000 children per year in Tanzania with sickle cell disease if you don't have hydroxyurea, if you don't have medication, if you just had folic acid and the hospital to give them. So if newborn screening doesn't come with a whole package of medication, of penicillin, of immunization, of care, and of education, if the parents aren't taught how to see an enlarged spleen, how to identify a crisis, how to identify that an anemia, they don't take to the hospital on time, and we can't intervene clinically on time. So I think this whole package that includes screening, medication, also has to include education. And finally, I want to give this remark. Yesterday we were talking about this debate between giving hydroxyurea or bone marrow transplant and gene therapy. This is an important debate ethically in terms of the whole medicine. Should we invest more in prevention or in curation? But I don't think in sickle cell disease we have to focus in this debate, because this is the place where everyone wants to put us for many years. The place to beg for one thing or another when we have to demand. No other specialty is dealing like cardiologists aren't asking themselves, should we invest in anti-hypertension or in cardiac transplants? No, there are specialists in these medication, preventive medication, and then we have cardiac transplant. One thing doesn't overcome the other. And cystic fibrosis, we don't talk about either antibiotics or lung transplants or advanced care. They are complementary and they should be seen as that. And I think we are in this moment that we have to stop begging and start to demand, because until now we knew about the reality, but politicians, main stakeholders didn't have the data. Now we have the data and we can say, like, if Tanzania has 2% of newborns with sickle cell disease, this means 40,000 babies per year. This is more or less half of every new case of all the new cases of HIV in Tanzania per year, or the new cases of tuberculosis per year. And investment in sickle cell disease is the investment that needs to be done is really shorter and more little than the ones in tuberculosis and HIV. We are speaking about electrophoresis, isoelectric focusing, of rapid tests with hydroxyurea. That's not an expensive medication. So what are we waiting to? And this has to be told, and it has to be done. Thank you so much.
Fantastic. Thank you very much. Great. Thank you. I think open up with Dr. Lucretia to comment possibly on the last speaker. Also Dr. George, if they can comment, and then we will conclude with some comments which were specific to Tanzania to our two panelists from Tanzania. Thank you.
To comment about the shows of treatment.
Yes, he talked a lot about education, which is your area, the baseline that needs to be, yeah.
My area is whole. My area is genetics, is scientific researcher, is love, is everything.
Okay.
In sickle cell, my area is whole. But I want to comment on education. In our work, we have 1882 members in active members on sickle cell disease organization on Gabon, and we organize education in high school, university, and screening with a sickle scan test every year, and it's free. We remark that the first need of people in my country is information, is the basic. And when we say, since yesterday, we asking, what is the priority? And we must to choose between everything, treatment, screening, everything. For me, if I have money, I will put this money in education and information, because in our country, they think that sickle cell is a spiritual disease and is not concerned our population. It's concerned another country, another population. If we arrive to put in the mind of people that sickle cell disease is a rare genetic disease, I think is will a best result for first round. And then we will go to genetic counseling and see screening, everything, and newborn screening. But first, education and information for me is the first level.
Fantastic. So I think we'll pass George. And one of the key questions I think that has been coming up is about the priorities, not to compete, but to complement each other. And I'm wondering whether from your NCD experience, how sickle cell disease could be actually implemented in the public health sector in a complementary way with other major health concerns. Thank you.
Thank you, Victoria. So we've got this leaflet. We've got maybe more than 10 partners here. So I bet with you that these representatives, they don't know each other. So maybe we can start with the coordination. And Isaac said it yesterday about the coalition. We need to have someone to coordinate the technical program in Africa. So secondly, I would like to say that it's not easy working close to the communities. And we cannot expect to move the specialists from the city to these rural areas. So, but we can try to shifting their activity, having the steer committees, designing the protocol, help our colleagues that they are working in a rural setting. So that's all my study.
Great, thank you. So I think we'll move to Dr. Omary and Dr. Ntuli for the questions that were specific for Tanzania.
Yeah, I think that was just a concern from Dr. Deo. He was thinking that I was against premarital counseling, which is not the case. It was just a reminder to the team, if you know the relay, when someone is running with a stick on the hand, then you pass it over to your colleagues. You are the same team, like a football team, basketball team, and you know the potential. If you have a potential of being a goalkeeper, please don't play as a number 9 within your team. We know you're a good player, but you are in the wrong position. This is what I was calling upon colleagues. In most cases, we researchers, doctors, we are acting like nurses, we are lab scientists, we are politicians, we are health promotion activists, and everything. We all embedded into doctors, which in most cases, we are not good in all of those areas, but rather people are sitting aside looking at us. My concern is when we know the science, we have to pack it and pass it over to the people who can deliver it well in the community. And in this case, we need people who are living with sickle cell to pass on the messages, because community will understand them well than doctors. When a doctor talks to the public about a disease, people tend to shun away from the disease. But it is very unfortunately, we don't see a disease, we see a person, and then we shun away from a person, which in most cases, it is counterproductive. So what I was calling upon is just, we know the science, everything, pack your message, pass it over to colleagues who can deliver it better in the community, but also who can put emotion into it. When a Rafa is talking of difficulties in accessing hydroxyurea. I do remember the other time when we were with the permanent secretary, Professor Kamwabwa and Professor Balandya didn't make it very clear. But when Rafa was talking to permanent secretary, he was moved right away because he understands the suffering that the patient has. So, Deo, I'm 100% into premarital counseling and screening. That is plus to us. But we need also the colleagues on the ground also to play advocacy role.
Thank you, Dr. Ubuguyu. And I'm so happy that you're emphasizing having advocates working with you guys, as you might be the clinicians, the researchers, and everything. But when I'm talking to a mother or talking to a patient, it goes directly to what I go or a mother goes through. So we are waiting for that collaboration very warmly, because we've been trying our best, or we are doing our best to be there with you guys. And you need to see us because we are doing a very good job. I'm not bragging, but you've been displaying it all over, but I haven't seen anything from you guys recognizing the advocates for what they actually are doing. So I know I'm not here alone. We have advocates from different countries of Africa, but also we have advocates from Tanzania also who are doing very good here. So I think it's encouraging if I be encouraged from the Ministry of Health, good, and it's seen, it's appreciated, not only on symposiums and the meetings, but I think needs to be carried out well, that the advocates are there and they are doing a very good job, and not just bringing us somebody, but we are doing very good job. So thank you so much.
Thank you, Mimi. I should start from where that the sickle cell disease should be taken as a movement and not a moment, and as the marathon and not as a sprint. And maybe a bit to respond to what Dr. Soka said, we need to have band of interventions. The science tells us number of interventions which have proven to be working pretty well. Let us invest into those interventions. With regard to the question which was asked by Dr. Lulu, so in Tanzania, we have different arrangements for the urban and the rural settings. For the urban, we do not have villages. We use hamlets and streets. So for Dar es Salaam, it's treated very different from other regions due to its population size. That's why we have 3 regional referral hospitals. In some of the councils within Dar es Salaam is up to 3 hospitals. So the way we treat Dar es Salaam is different due to its setting and also the population size. And with regard to what commented by Iam, I think we must know that where we manufacture our data is at the primary healthcare level. So in Tanzania, we are trying to digitize our primary healthcare level, moving from paper-based data system to electronic data system, because we believe in so doing, then we shall be ensuring the quality of data. But the other thing is to find a way, how do we engage politicians, the policymakers? That's why I said we need now to move a little bit from the clinical-based research to the public health research. We need to have investment case. How much do we get as a return on investment by supporting a single sickle cell patient? These are the words politicians would love to hear. How much do we get as a return on investment? So the economics of the sickle cell disease should be our top priority for us to present a case to the politicians. But the other thing is regarding the health education. The system which we have, particularly in Tanzania, we have a very good dialogue structure from the ministry level to the community level. And we have different platforms to offer health education. We need to exploit that and make sure that we communicate our messages across different communities. And this community, not only the patients, rather the general population, because the stigma starts from the general population. Thank you very much.
Thank you. So I think Dr. Place would like to add a few comments. And while she is adding a few comments, I thought it might be really important that we also hear of some success stories of public health interventions that have been implemented in other countries, because we've had quite a lot from Tanzania. I mean, very great examples. So I think she wants to add a few comments, and then we'll call up our representatives from just to give us a few examples of pilots or interventions that they think could be scaled up and other countries could learn from. Thank you.
Okay, it's not a real comment. It's just to say that we have a scientist and we organize whole research in Gabon, and we want a partner. We research a partner for research. And next year on 2024, we organize a third Congress of Sickle Cell Disease in Gabon. So you are all invited.
Fantastic. I think it's great to have Gabon invite us to the next symposium. And also, I think a call by Dr. George to make sure we are also inclusive of other countries in most of these meetings, the Portuguese countries. I think it's very clear that the network of sickle cell researchers and stakeholders across the continent really needs to come together. So I think I'll call upon a few representatives from different countries who might want to highlight key lessons in public health interventions for sickle cell disease. I'm not sure if Professor Kiguli is in, or a representative from Uganda, if they might want to just share a few lessons or comments that other countries could pick up from. Oh, it's fine, because I think some questions might come. Great. Just a show of hands if there's anyone else who wants to say something. I know Zim is still in its early stages. Maybe just highlight some key lessons you've learned as well. Zambia is way ahead in terms of newborn screening. That's, some lessons that other countries might pick from. And Congo, I mean, the World Sickle Cell Day really started from Congo. It might be great to hear from Professor Shilolo, some lessons that other countries can take home with them in terms of really impacting public health.
Thank you, Vicky, and thank you, the panelists. Just to share a little bit on the Uganda experience, we were able in the year 2015 to conduct a screening testing program with the help of the EID samples of the HIV program, and we were able to know the prevalence of sickle cell disease in Uganda by region. Now, based on that, we were able to focus our resources on areas where there was a high burden. So in terms of public health interventions for countries that have not had an opportunity to do such a survey, it will help you focus where your resources are and limit how much you spend in areas where, as someone said, the return on investment will be low. So that's the experience we have from Uganda. Thank you.
Fantastic. I think we had Chance and Professor Chilolo. from, yeah. You know, no, it's fine.
Thank you. In DRC, we have, I can say, multiple experience on introduction of newborn screening in DRC. Many years ago, we introduced it in Kinshasa first. We were the first. I was working in a private hospital, but we had public health vocation because of the convention with the state. It's a Monkole hospital, and we introduced for the first time the newborn screening as a pilot study. After this first experience, we enlarged the zone in which we made the newborn screenings. But I just have to say that it was in the period where we introduced also the HIV program. So people was a little bit, there was not a great agreement to do the test, no, because they think that when we collect blood on a paper, that means HIV test. So there was a little bit reluctance, but we used to make many informations. We make many educational programs in the medias and so on. After, I can say 1 year, 2 years, we see that things are going better in urban areas. I'm just talking about Kinshasa. And we made this program in the big maternities of Kinshasa. And after that, we introduced the same program in the neighboring regions of Kinshasa, in the semi-rural areas, in Congo Central, in Katanga, and in Kasai. In Kasai, in the middle of the DRC, this experience is new because it's one of the region, the province, where we have a very high prevalence of sickle cell patients. And they are also, there's also a high stigmatization. They're thinking that it's a malediction and so on. So we introduced the new equipment and the new devices by making the training of the local personnel and making many radio and TV program for information of the people. We have got a good opportunity to work with to work also with some NGO, just like Novo Nordisk Hemophilia Foundations, who plan to make a screening of hemophilia. So we combine both. With the same team, we are able now to check for hemophilia and sickle cell disease. And I can say that now our government is more allowed, and this advocacy is going well because the foundation of the First Lady is dedicated to sickle cell disease. Last year, we planned and we realized for the first time a targeted screening in pregnant women. This step, I've seen that in the Tanzanian program, we plan to do it, no? It would be a good thing. I will tell you why. Because the cost will be reduced. When we do the targeted screening in pregnant women, in DRC, a woman has 5 children. That means that you reduce by 5 the number of screening if you will need to screen every newborn. And another reason is that when the woman knows that she's a carrier, she will talk to the husband. She can sensibilize the husband. Is a kind of genetic counseling. It's very important. And the cost of these kind of program is less than the systematic newborn screening. So I think that this experience allow probably my country to introduce these targeting screening in the rural areas. So that's the experience. I think that for me, I think that it would be possible to introduce, but step by step because of the financial problems. Thank you.
Fantastic. Thank you so much. I think we also have Dr. Chunda who wants to give a comment.
Thank you very much. I would like to begin by acknowledging the fact that the collaboration that is going on right now is one big success story that we should very much recognize. And speaking from my country, we have begun newborn screening in the last 2 years. And again, because of the collaboration that we have with some of the institutions that are here, we've been able to make a great stride. And in our attempt to do that, we have recognized that it is very important that you begin it with the Ministry of Health and not just the collaborators that you are working with. And because of that, of course, we have made a great stride so that now we are talking about taking this facility to primary healthcare facilities, which are, of course, manned by the Ministry of Health, and we are getting the support from them. And further, I would also recognize the fact that most of the work that we have done would actually not have been possible if we did not have the support of the parents and the patient support group. They are the one many a times who put the pressure on us. They are the ones sometimes who've even gone ahead and approached Ministry of Health to provide certain things that they need, certain things that we need as well as healthcare givers to provide the help that they need. One very good example is just the last World Sickle Cell Day celebration that we had. Earlier on, we had a meeting with them where they actually demanded we want the minister to come and address us this time around because we've got things that we would like to relate to her. And they made it happen. I know on my own with my unit, that would have not been possible. I'm not sure how they did it, but they did it. And the minister did come. And because of that, she's actually made very significant commitment, you know, to what she will be able to do. She says if she's going to be in the office, and we hope we can celebrate the day again with her next year, because she says she does not want to hear certain things mentioned by next year. She's hoping to make sure that they happen.
Fantastic. So I think for our last 3 speakers, we'll just give them 1 minute each because we're running out of time. And we do have some comments you can give patients, and then there are 2 more that side. So we also have a lesson from Jamaica, from Jennifer Knight, the importance of written national policy on SCD. Technical working group includes patients, researchers, representatives from all authorities, and monthly meetings to move programs forward. The importance of universal screening and early childhood care, the importance of ongoing training for healthcare workers. So we'll give you 1 minute each, and then, yeah.
Thank you. I don't have much experience to share, but I've been listening to the contributions from the floor. We are going to pilot the newborn screening in Zimbabwe. via the Sickle in Africa Consortium newborn screening study. So we are excited. We're using point of care tests for the first time in the country. We are actually to be validating the tests, and the ministry is actually waiting for that validation to then see if they can uptake the point of care tests for the country. But obviously we are worried about when we identify the children with sickle cell disease, we need to link them to care. So we are carefully planning this pilot, so because it's a kind of implementation science, to see how we can then in one of the district hospitals where the districts with their what we think the highest burden according to our registry, we get a lot of children with sickle cell disease coming from this particular area. So that's where we have gone, and we will be sharing our experiences. Obviously, we are being by countries like Nigeria. We'll share a lot of experiences with them and a lot of mentor. If we have big them, thank
you. Yes, I would like comment. We said newborn screening would be a package. It is very important, this point of view. We are we have a big enthusiasm for newborn screening or all the kind of screening. If you have not training for health worker to have management of sickle cell patient, you reveal by newborn screening or other screening, you are doing something which is not ethical. A patient, it is important to have incidence of sickle cell disease in the population, but it is not ethically acceptable to someone to reveal a problem in a child and don't have to management for him. Don't pay attention to before a newborn screening would be accompanied by training to have management of the sickle cell patient. And the last point is I am not the point of view of Leon Chilolo because about targets. It is very it could be you have to adapt to every country. Some countries you have a certain level of beta thalassemia, heterozygosity, or sickle or C hemoglobinopathy, and so and so. In Diagne, the main problem is S, hemoglobin S. But if you go in other part, if you have targeted screening, you may have people who you tell that you have no problem to a mother, you have no problem with hemoglobinopathy, and she will have a child with sickle cell disease. You have to adapt it to every country. Thank you.
Fantastic, thank you. So I think we've got one last contributor, and then.
Good afternoon, everyone. My name is Phyllis Owino. I'm a family physician and a public health care practitioner. So what we're discussing on public health aspects of sickle cell disease and primary health care is not only my forte, but also my passion. I work with Pfizer in East Africa in the medical affairs department, and my comment is on healthcare financing. While majority of the African countries, especially Sub-Saharan African countries, if not all, are part of the signed the Abuja Declaration to say they would spend up to at least 15% of their healthcare, of their budget on healthcare. Some countries and most of our countries spend even less than this. And so when we speak about healthcare financing and on sickle cell disease, for instance, we need to talk to our governments and lobby so that they spend money on specific disease areas. For example, in this case, sickle cell disease, it is not enough for governments to spend money through NHIF, but they need to allocate a budget. Our governments allocate budgets for other NCDs, so let's say diabetes, hypertension, but none on sickle cell disease and hemophilia. To share experience from Kenya, there has been no focused person on sickle cell disease and hemophilia in the Ministry of Health for some time. And the Kenya Hemophilia Association has been able to form a technical working group that has lobbied, and there's been a focused person. And from these, for sickle cell disease, at least the guidelines on newborn screening were launched last month during Sickle Cell Awareness Day. So I'm glad that in this conversation, the Ministry of Health for Tanzania seems to be staffed by doctors. The chief medical officers was here, and I've had a number of doctors speak about, from the Ministry of Health, speak about this. So it is up to the other doctors in this room, at least for the case of Tanzania, I would say it is easier for you if you have doctors who are at the ministry to listen, because you can also hold them accountable as peers. It is not enough to say that to depend on partners, because that's not sustainable. The government must give a portion of its budget to healthcare and to specific disease areas. Thank you.
Fantastic. So I think I will just read a few comments from the participants online so that, we see them and we hear them while the panelists actually prepare their final statements before we close. But I think this has been a very fruitful discussion and a lot of take-home messages and a lot of lessons. And I think going forward, I'm not sure what Emmanuel was thinking, but it would be great to actually have these lessons, that are being shared around public health, put into targets and a plan of action. And as Arafa is saying, we don't just want meetings, we want continual activities after those meetings and discussions. Thank you. So online, there is Pascal Tuso-Jonot. He was cautioning against developing just a simple standard algorithm to identify those most at risk. And he says sometimes it could lead to discrimination and the first excuse about cost. But I think this mistake has been done by other countries. So that's food for thought. And another comment was that we do not lose our humanity in everything we do. Even if we're researchers, we're clinicians, working with sickle cell, sometimes you don't see the patients, but at least don't lose your humanity. And I think that's something that he has been stressing in the message. And I think that's something that has come out as well of one of our speakers' messages, that even though she is an expert in the lab, she's also really engaging with the patients and of the disease that she's also researching, which makes it, there are people behind the disease that is being studied. And even in public health interventions, one might end up thinking of everyone as a whole community, but at the end of it, everything you do boils down to the individual, even though we're doing it at a public health intervention. So I hope this has given enough time for panelists to give final words of comments, and then we can close the session. Thank you. So I would think we'll start with Dr. George at the end.
So just to say thank you very much for having us here. So maybe just for the ending, we need in Africa, we need some excellence center for training. So we've seen here in Tanzania, you are very advanced. We have to think about that. We have a regional training center on a sickle cell. That is could be very important for African region. It's just a recommendation. Thank you.
Thank you very much. I must appreciate for having us in this panel. And for me, I think we need to further decentralize the sickle cell disease interventions to the primary healthcare level. But I would like, and I wish to actually convince the audience that we should endorse the recommendations which were presented by Prof. Rion yesterday. I think those are quite well explicit. We need to endorse and come up with the action plans for us to start implementing right away. Thank you.
Okay, thank you guys for being with us, because when you talk and there's no audience, actually it is a little bit awkward. So thank you very much for being tentative and very energetic during contribution. My final comment is very personal. So I just give you a brief of my career journey. I was employed by a government at the district hospital, and I spent just 2 weeks with my boss, and then I dropped out because we had a very difficult moment with my boss within the first 2 weeks, and I became jobless 2 weeks after being employed. And I was wandering on the street, only to come up on the rescue of Dr. Soka and Julie Makani. So I joined Sickle Cell program as my rescue from the street. So I'm back home, and I spent almost 6 months within the Sickle Cell program. And I left the program when I was employed by Muhimbili National Hospital into the mental health department. And Professor Julie Makani, by then Dr. Julie Makani, was very happy, said that when you join the mental health department, then we work together with you because you know a lot about sickle cell, so you'll be part of our counselor. Only to find out in this consortium that they are lacking expertise on mental health. So I'm in debt with the sickle cell community because they rescued me when I was on the street, and I forget my colleagues. So probably from my side, this is my promise to the Tanzanian team that we'll form a team with mental health colleagues, especially since now we have clinical psychologists and we have a number of counselors on the street. Probably we can hook them with some of our programs.
You finish? I'm the last. I just want to say that in Gabon, we don't have a governmental program on sickle cell, but like in Kenya, we have private financial partner. And in NGO, we was done something like when we screening children first, second we give an practitioner to follow up, and then we have a recorder on governmental program on sick on long duration. I don't know, in French, maladie à longue durée. Yes, sick on long duration is whole health cover. Everything is take treatment, transfusion, everything you want is included in this program. And we don't have specific financial for sickle cell, but we help patients to include this program to have whole health cover on treatment and whole. And I think next program will be to include the Tanzanian BMT program, bone marrow transplantation for our patients. I will ask how to have a collaboration with hospitals to access in this program. And thank you, and I hope to see you next year on May in Gabon.
Fantastic. Thank you very much to the participants. You've been great, the questions, the contributions, and most importantly, we would like to thank our panelists. We've got a range of expertise, and also to are the researchers who publish, data and information that's pertinent to public health. And we're hoping that as you begin to really be inspired to look at the global map from a different direction, to change that heat map so that it's more gray and blue rather than orange and yellow. Thank you.
Thank you very much. A round of applause to Dr. Vicky for very able chairing of the session. Thank you very much, Vicky. Thank you, panelists, for a very engaging session. I must say that all the sessions have been really, really fantastic in these 2 days. So now it's 1:45. We will break off. We'll have 45 minutes of lunch, 45 minutes, and we'll convene back at 2:30 for the last session. It will be titled COVID-19 and sickle cell disease. So Professor Chilolo will be chair of that session. So bon appetit.
COVID-19 and sickle cell disease. We know that COVID-19 pandemic was a great event in the world. And in this session, we will try to see what was the impact of COVID-19 on the health of patients suffering from sickle cell disease. So I'm happy to introduce Professor Jean Nachega from the University of Pittsburgh and AFREHealth. Professor Jean Nachega is a professor of medicine and infectious disease, microbiology, and epidemiology. He's working at University. He's working at Pittsburgh University and also in Cape Town in South Africa. We are grateful to him because he contributes to make new contacts between different African researchers. And you are welcome, Professor Nachega, for your talk. Welcome.
Thank you very much. Thank you very much, Professor Chilolo. It's really a great pleasure to be back in Tanzania. My last time I was in Tanzania was before COVID, and as for most of us, it's really great to be back again, almost to normal life, and we can talk together without a mask anymore. So it's a big change. So I have only about 20 minutes to just give an overview of what we're doing about understanding what was the impact of COVID on sickle cell disease patients. And I will start just to show you a big picture about the epidemiology of COVID. And it's really striking when you look at this slide. The hotspot of COVID were in United States, in Europe, and somewhat in India. And really surprisingly, Africa was kind of spare. And this was a big surprise for most of us, and because there was an early assumption that Africa going to be devastated, given all the socioeconomic challenges of social distance and the other issue or poverty. So the panel that follow my talk will try to debate all those, what the reason why Africa was somewhat spare. But before we get there, I will just also share personal experience. As for most of us, we've been affected in one way or another by the COVID. I lost my mom, and I know some of you in the family lost one of member of the family. And I mean, when you compare the HIV death to the COVID death, it's just something that we will never forget. So those two pandemics will stay forever in our memory. And so coming back to our reality here in Africa, so somewhat God was with us about COVID. As I say, this could have been even more drama. And the big reason is Africa is a relatively young population. And as most of death in Europe, United States, and elsewhere was mostly elderly because of accumulation of comorbidity. So having a young pyramid age did help Africa in some reason, but that's not the only reason. The other reason is probably there is some evidence that we've been exposed to other kind of strain of coronavirus that give some partial protection, immunity to COVID. And I think Professor Gonzalez can talk about this a bit more eloquently later. So there is multifactorial reason why Africa, despite its challenges, was fair compared to the other continent. So Africa, AFREHealth. I belong to the African Forum for Research and Education in Health. It's a multidisciplinary organization, originally created from Medical Education Partnership, PEPFAR, including several medical schools. In 2015, the MEPI and the NEPI created AFREHealth. And one of our mission is to try to disseminate good practice, medical education, promote medical education, but also research. So during the COVID pandemic, as for most of us, all our essential research was closed. I am an ID infectious disease specialist, HIV researcher. So my research was closed. We were asked to stop what we've been doing. So by default, we all diverted COVID. And I was locked down in Cape Town. And I asked myself, well, how I can make my time in the lockdown of use. So that way I say, I'm going to use my AFREHealth network. I take my phone, I call Jean-Jacques Muyembe, the co-discoverer of Ebola virus in DRC, and say, Jean-Jacques, you are the task force response to COVID in DRC. What's going on about COVID in DRC? Most of data we're getting are coming from China, from Europe, from United States, but we don't know what's going on the African continent. So we just collected data retrospectively of that was collected as routine. And we realized while Africa was somewhat spare for COVID, there were still people getting COVID and dying, not as big number like in Europe or in US, but those who are being affected also they share the same risk factor, comorbidity. But what was striking was when we realized that people less than 20 from data from DRC, we saw that, look at that Kaplan-Meier, children with or adolescents less than 20 years, mortality hazard of death was higher than young adults. So that was kind of surprising because from data coming from Europe and US, children were less likely to affected by COVID and less likely to die. So something was going on in Africa that despite being spared, those who've been affected, the epidemiology was somewhat striking. We also noticed that those ending up in ICU, mortality was about 50%. So that did motivate me and colleagues through the AFREHealth network to call for pulling data across more than one country. So because our data from DRC was kind of a small sample size, to try to confirm what's going on the continent, we called to pull data across 6 countries and looking at pregnant women and also adolescents. And the data we managed to do the study. This was in children, and Professor Chilolo was one of the investigators in Kinshasa at Monkole Center. And we basically, through this high-profile paper in JAMA, we've been able to confirm basically that, yes, mortality was about 10%. Those children in Africa being affected by COVID, mortality was higher than what mortality reported in the US or Europe, which was less than 3%. So we had high mortality. The data we got came from Ghana, Nigeria, DRC, Uganda, Kenya, and South Africa. So, and we also, so this is where sickle cell come in the picture. Our motivation to do this study was also to look at what were special or kind of specific for Africa in terms of comorbidity, like malaria, HIV, tuberculosis, and sickle cell, how sickle cell is being affected or do impact mortality. So despite the number of sickle cell disease patients in this study was relatively small, we've been able to, across the 6 countries, we've been able to see some alarming signs, some red flag that sickle cell anemia patients were more likely to be admitted in ICU and more likely to die compared to other patients. So same story, looking at pregnant women. Also, the data collected across 6 countries did confirm that pregnant women compared to non-pregnant were more likely to end up in ICU and were more likely to also die compared to non-pregnant women. And here again, specific comorbidity for Africa, like tuberculosis, in terms of prevalence, and HIV were risk factor for ICU admission. And again, sickle cell anemia, pregnant women with sickle cell anemia, high risk also of being admitted in ICU. So those data raise our, really raise the flag. And that's why today I've been invited to talk to you, because this data did trigger us to try to secure funding to do a much better study that's specific to sickle cell disease patients, and not only across few countries, but about 10 countries in Africa. And the reason here, again, is that Africa has its own comorbidity that may affect COVID, and COVID may affect those comorbidities. So it's kind of bidirectional. And data from US did confirm some excess mortality in sickle cell diaspora patients in the diaspora. And when you look at the physiopathogenesis of sickle cell disease and COVID, they share some similar pathway in terms of vascular necrosis and other kind of thrombosis, vaso-occlusive events. So it's not surprising that both diseases can affect each other in terms of morbidity and mortality. And I'm sure the panel, some of the immunologists will elaborate this more eloquently than myself in terms of those common pathway between COVID and sickle cell disease in terms of the pathogenesis. So this is the study that is taking off across 10 countries. And and several of the PI are in this room. It includes Angola, Professor Dr. Brigida Santos, Cote d'Ivoire, Gustave Kofi, Prof. Chilolo in DRC, Prof. Lucrece from Gabon, Alex in Ghana, Prof. Nodu from Nigeria, Julie Makani from Tanzania, Sarah Kiguli in Uganda, Catherine Chunda in Zambia, and Patience Kuona in Zimbabwe. And basically, we try to understand the impact of the mortality before and during COVID in patients with sickle cell, and to look at the reason of mortality, and also to look at any kind of bidirectional effects between those two diseases and other several questions. So this is also, it's not prospective, it's a retrospective data on anonymized data that were collected during the COVID pandemic period and before. And we're gonna just try to retrieve all the key explanatory variable and outcome variable. In terms of explanatory variable, we're gonna also look at health system level variable. We have a very comprehensive data analysis plan across 4 M's. I don't have time to go through them. And this study is supposed to, currently, countries are trying to seek IRB approval, but we expect by August, we'll be starting to collecting the data about in September to analyze them, and before Christmas to disseminate this data. Hopefully, we're gonna submit it to the Lancet Global Health or to the Lancet Hematology. So that's all. I would like just to thank my collaborator in South Africa, University of Pittsburgh, at Johns Hopkins. Most of my funds are NIH. And also I would like to acknowledge AFREHealth Platform Life Science, who supported my trip here, and also all my collaborators in the room. Thank you.
Thank you very much, Professor Nachega, for this great study that highlights the role of sickle cell disease, the role of COVID-19 pandemic on sickle cell disease. So now I will invite Professor Jean-Paul, I will invite the next speaker, who is be online. I suppose she's online. She's the technical assistant. To just a moment, sorry. Next slides. The next speaker is Dr. Ashima Singh from USA. She's a professor at the Department of Pediatrics at the Medical College of Wisconsin. She's a PhD in epidemiology, and she has the advantages to have been involved in the creation of secure sickle cell disease registry. I suppose she's online. So, Doctor, please start your communication. Is not able to unmute themselves. Hola. Yes, that depends on the. Is it okay now? So it's okay now, please.
Yes, thank you so much, for the invite. And are you all able to hear me okay?
It's okay.
Okay. Should I share my screen? Is that how we're doing?
You can go on,
Thank you.
please.
Just a minute, please.
Are you sharing your screen?
Yes. Do you see the full screen presentation? Yes.
Yes, you can proceed, please. Go on.
Okay.
Thank you.
Thank you so much for the invite, and it's my pleasure to talk about the work that we did to understand the impact of COVID-19 among individuals with sickle cell disease. And I'll go through my slides in about 10 minutes and hoping for a discussion after that. My slides. So the Secure Sickle Cell Disease Registry, I was closely involved in the creation of that. And just a little bit of background, when COVID-19 hit, we, of course, none of us had any idea of the impact of COVID-19 on the general population or on individuals with chronic conditions, including that of sickle cell disease. So there was a need to establish a rapid reporting registry to collect data on COVID-19 illness in individuals with sickle cell disease. And this was modeled after a similar registry that was created for another condition, inflammatory bowel disease, and we had already started seeing that registry was able to get a lot of information on the impact of COVID-19. So I have to acknowledge here Dr. Julie Penapinto, who was working at Medical College of Wisconsin and now is at NIH. Under her leadership, we created the registry, and the registry went live on March 20th of 2020, only 9 days after the proclamation of pandemic. So what was the Secure Sickle Cell Disease Registry? It was a voluntary provider reporting system wherein we collected only de-identified data for individuals with sickle cell disease who have COVID-19. And what we collected was patient demographics, sickle cell disease, medical history, comorbidities, a little bit of COVID-19 severity, complications, outcomes, and the management strategies. And how this was done was we had this web page wherein there's a case report form where the information could be completed. The registry is now closed for reporting, but this graph kind of shows how the cases, both children and adults, the number of cases evolved and how the registry evolved as the pandemic proceeded. There were a lot of unknowns. So when we started the registry and as we got more information on therapies, on vaccines, on reinfections, we attempted to keep our registry updated and continued to add those questions. It's a national and international registry. So we had cases reported from a lot of countries across the world. But the majority of the cases that we got, 87% of them were from the United States of America. And this map shows that there are multiple states that reported cases, highlighting the generalizability of the finding for within US. As I said, that we collected COVID-19 severity information, and our classification of COVID-19 severity was based on one of the initial papers that came from mainland China that categorized COVID as asymptomatic if there were no clinical signs, mild if there were symptoms of acute upper respiratory tract infection, including fever, fatigue, myalgia, cough, sore throat, runny nose, or sneezing or gastrointestinal symptoms. We consider it moderate if there were pneumonia with or without clinical symptoms. Severe, of course, if they had early respiratory symptoms or gastrointestinal symptoms followed by dyspnea or hypoxia, and critical if they had acute respiratory distress, failure, encephalopathy, shock, or multi-organ impairment. The graph here shows that for both children and adults, a large proportion of cases were mild for COVID-19 severity among individuals with sickle cell disease, but there were still a chunk of people who had moderate, severe, or critical illness. So using the data that we had, we wanted to understand the risk factor for serious COVID-19 illness. So what is it that among the sickle cell disease population makes individuals at risk of more serious COVID-19 illness? So we use the registry data, and here I'll just highlight the results in interest of time. The paper is published, but we looked at risk factors adjusting for various comorbidities for both children and adults. And what we found was for children who have children with sickle cell disease who have COVID-19, if they have heart or lung comorbidities, or if they have renal conditions and a history of pain, I say 3 or more acute, as identified by 3 or more acute care visits in the last 3 years, then they are at risk of more serious COVID-19 illness. For adults, it was only the history of pain that was identified as a risk factor for serious COVID-19 illness among individuals with sickle cell disease. Another way that we looked and tried to understand the impact of COVID-19 on individuals with sickle cell disease is using big data of electronic health records. So we have access to a research network that includes de-identified patient level data from multiple sites, and these data are refreshed on a regular basis. And here, using these data, our study population included patients with COVID-19 during the time period of January 2020 to September 20 of 2022. And the patients population, as you can see in the second main bullet, there were 3 patient population of interest that we looked at: patients with sickle cell disease and COVID-19, patients with sickle cell trait and COVID-19, and COVID-19 among Black individuals who did not have sickle cell disease or trait. And when we compared the outcomes, we saw that individuals with sickle cell disease, after matching for age, gender, and clinical comorbidities, had a much higher rate of hospitalization, almost 2 times higher, 2.4 times higher rate of pneumonia and acute chest syndrome, and 3.4 times higher rate of pain as compared to other Black individuals who did not have sickle cell disease or trait. And there were but interestingly, we did not observe any significant differences in mortality between individuals with sickle cell disease and trait. So I think these studies and results warrant discussion on collaborations for how near real-time reporting of de-identified data via various online case report form is a quick and simple way of gathering valuable information to inform health and clinical outcomes. Also, big data of electronic health records for conditions like sickle cell disease, especially in the US, is considered, even though it's considered rare in US, it's the most commonly inherited blood disorder, and of course is much more prevalent in Africa and other subcontinents like India. So for the sickle cell disease population, national and international collaboration is imperative. And specifically for COVID-19, I think there is still some work that needs to be done, including consequences of long COVID-19 among individuals with sickle cell disease and predictors of mortality. That I think a lot of work that Dr. Nachega is planning to do touches on the mortality aspect. So I will stop here, and I would of course want to acknowledge, before stopping, I would want to acknowledge Dr. Julie Penepinto, Dr. Brando, who led the development of the Secure Sickle Cell Disease Registry, and the entire sickle cell disease team and the informatics team at Medical College of Wisconsin that made this work possible. So with that, I stop my screen share and will be happy to answer any questions or get into the discussion.
Okay, thank you very much. Great work that would be discussed with the audience. Now I will invite Professor Jean-Paul Gonzalez, who is working in Georgia, in Washington, in USA. He's a virologist. He has good experience on many viral infections in Africa because he worked in some of the African research centers in Republic of South Africa and recently in Gabon. Professor Jean-Paul Gonzalez is also the vice president of the REDAC, because for the REDAC, sickle cell disease, we have One Health vision of these disease. Jean-Paul, please, are you online? You can give your talk. Welcome.
Yes, thank you, Dr. Filolo. Thank you very much. So I have to share my screen now. And that's it, and we are there. So can you see my slide?
Yes, we are seeing it. Can you use the...
Yeah, sure, I do it.
Okay. It's okay. Yes.
Let me switch from one. Yeah. Can you see the full screen now?
Yes, it's okay.
Okay.
You can proceed.
Okay, let's start it. Yep. I'm in the middle of the reading. Okay, thank you very much for inviting me. Thank you, Dr. Filolo, for our friendship for so many years. So I'm presenting this on behalf of Dr. Filolo and all our group. I will recognize our knowledge at the end of this presentation. So this is about COVID-19 infection and SARS-CoV-2 immune response among sickle cell disease as compared to the general population. So this is very important observation, and regarding the previous presenter, and thank you for Dr. Nachega for presenting the basic of this, I would say, discrepancy between African population and the rest of the world in terms of incidence and prevalence of the disease. So let's see what we are going through now. So first of all, I will present this about the COVID-19 pandemic immune response in general, and then the pre and post COVID-19 immune response. That's a very important part, before the pandemic. Did the people have some kind of immune response against this coronavirus? And then the challenge with the sickle cell disease patient and the infection with the SARS-CoV, and then the concluding remarks. So this is just a brief summary of what we are trying to investigate. IgM, IgG, 6 weeks. So this is a long process of production of IgG, and IgM, as usual for the viruses, is a short process, 6 weeks, and with fading after 6 weeks. So this is give us the dynamics of the infection. That's important about the time. So several papers have been published regarding this high prevalence of pre-existing serological cross-reactivity in Africa. So this is a paper, one of these papers. There are several others, but this is an interesting thing, interesting presentation about the SARS-CoV-2 infection may have been present in the US in December 2019, before the COVID-19 pandemic. So we are talking about the US. Blood donation source. Second paper, another paper, pre-COVID-19 immunity to common cold human coronaviruses. Industry cold type IgG. So this is a long immune response, this IgG. And predicting against pre-existing immunity of COVID-19 on herpes of several beta coronaviruses. And then we have this observation in Delhi, where the percentage in the urban population is much higher than the general population. So just briefly what we did, so we explored several samples from Africa, sickle cell disease and general population, and we use this technology, which is a very interesting technology that can be really carried out in a very basic BSL-2 laboratory. And as you can see, this using the immunobiology, it's a multi-serological assay of IgG to SARS-CoV-2. Okay, and then when you are reading, this is a negative spot, and when you are reading a spot, it's very simple, very easy to read. When we have a spike here, positive S2, S1, different part of the spike, and the nucleoprotein, and all the different N-terminal domain and receptor binding domain, which are very important in terms of immune response. All these proteins are very important in terms of immune response. I just gave you the summary of the aspect of this SARS-2 with the different spikes and different surface protein here. So just to give you that the information that this test, it was pretty practical. Used in different countries, in Cameroon, in DRC, in Congo, Republic, etc. So that was easy to use and very efficient. So this is the result. This is the result we got. It's a pre-pandemic cross-reactive immunity against SARS-2 among Central and West African population. This is our team here. And this is the positive response above the negative control. So we have this in Cameroon, very high here. And we have this nucleoprotein, which is as expected, And then we have the S2, which is part of the spike protein, pretty high also. And the S1, it was no difference, expected also, but a very strong variation. But this is okay. I mean, this is not really unexpected. Okay, so what is important is to see this value, percentage value above the negative control. The result was the tested population have been pre-exposed before COVID-19 pandemic to antigen of a yet non-identified coronavirus. So that was the conclusion of our first paper. And this is just to elaborate of this pre-exposure, the consistency and specificity of SARS-2 COVID immune response among this population, the antibody response against the S2 binding site protein, which is potentially neutralizing antibody. So this is what we have to look at now, and the prevalence overlap between human Chiroptera and antibody prevalence in Africa. So that's also the map of the human seroprevalence and the map of bat species prevalence. And we know before that Southeast Asia has what happened in Africa. Since the beginning, the prevalence was lower than in the rest of the world, and we have the same type of observation of seropositive bats against coronavirus. So that's really striking. That was published already, and 2 days ago, this is what happened. This is just I got this this information from Nature about this morning, in fact, and it was published 2 days ago. That means individual bat virome analysis revealed co-infection and spillover among bat and virus zoonotic potential. So these people, including my several colleagues, they are signing this paper. They observed that more than 60 viruses, they are common to bats and animals and humans. So are zoonotic risk. And among them, there is a major concern, virus of major concern, rotavirus, coronavirus, beta coronavirus, and myxoviruses. More than 25 of these viruses has been detected in these bats. It can potentially infect humans, and they are not yet infecting humans. So this is an important paper, and this is in favor of our observation. So now the third step is to see what happened with the sickle cell disease patient in terms of susceptibility and immune response to the SARS-CoV-2. Patients with sickle cell disease are theoretically at greater risk, that we saw in the previous presentation, of serious illness due to underlying pathophysiology, comorbidity, etc. We know that, and the chronic inflammation, which is major in terms of sickle cell disease and infection and infectious disease. So this is a population we explore, 37 sickle cell disease patients. This is the general population from the blood bank sample. So it's a good number of cohort. And the method was ELISA and chemoimmunotherapy, also a very strong immunological test, very powerful. So this is what we observed. This is what from the cohort from Dr. Tilolo for the sickle cell disease patient under treatment with other hydroxyurea. So this is the proposal, the cohort here, and this is what we observed in terms of response of IgM, IgG in percentage. You know, I just put in percentage. The second line is without treatment, and then the two control from urban and rural area, general population. And this is a result. This is an interesting result. So the difference between the people under treatment and without treatment was not significant here. This is what, when we analyze it, but when we group IgM and IgG, then when we do the test, we separate IgM and IgG, the statistical test. So this is highly significant. So this is highly significant between the people treated with treatment, so 18 and 22. Oh, I'm sorry, this is the period is missing here. Okay, 49.6. So in terms of percentage, so this is clearly significant. And then when we compare the control, so that's another comparison, another study, we can see that the people in the urban area are significantly higher infected with a higher prevalence than in the rural area, which is not really surprising, because the context of the urban area and the proximity and the density of the population. So this is another observation we have to pull together with what we observed before. So again, this prevalence in general, this is a dynamic of infection from the SARS-2 and the observation we did. So 2020, 21, and 22, and we can see clearly the increase of the prevalence of antibody against SARS-2. And this is clear between 20 and 22, and between 20 and 22 for IgM and IgG. So this is clearly highly increased. And then we have this tendency between the 3 years of increase. You know, we can see the tendency, IgM, IgG are increasing, and IgM are cumulative here. This is very clear. We know that this variant were responsible of this high IgM response. So because the variant was highly infectious and more than the Delta, the Omicron variant. So in conclusion, for this observation, so this is what we understood, and when we conclude that chronic inflammation in sickle cell disease accounts for a hyperstimulated state of cytokine, including the interferon-1, giving a basic potential resistance to infection, because the interferon-1 is again fighting against the infectious infection, and in particular against the viruses. In rural areas, the pre-existing cross-community against SARS-2 may be in favor of the low COVID-19 prevalence. So this is what we hypothesize, that this immune response, this pre-COVID immune response, was in one way protecting this rural population. The original sin, again, this bat coronavirus exposure could be attributed to the SARS plague hosted by bats. The seroprevalence increase observed in the last 3 years is potentially due to the Omicron type variant, which is much more infectious than the Delta variant. This is pretty classical and pretty understandable. The positive effect of observed sickle cell disease patients treated with hydroxyurea against SARS-CoV infection are confirmed and give this molecule a promising character to protect against coronavirus infection, at least SARS-2, and potentially other viruses. The study limitation, so by age, so that was one of our limitations, and Dr. Nachega present that the importance of different age classes, toddlers, children, adults, and adolescents were not really regularly studied in terms of ages, and we didn't see any apparent difference between the sex. So that's just another observation, which is we can think about that. So in conclusion, two things: that there is clearly in Africa, and we are demonstrating that in Southeast Asia, pre-COVID exposure to the natural SARS-like viruses certainly present in bats. Some other animals can carry this type of viruses, but beta coronaviruses are found in bats. And as I mentioned, this paper from 2 or 3 days ago, there is a lot of potential spillover from these bats to humans and to other domestic animals. The second thing is about the less impact in the rural area than in the urban area of the SARS-2. And the last one, which is certainly the most important, it's a potential effect of hydroxyurea against virus infection. In conclusion, repurposing the hydroxyurea against COVID-19, it's a promising immunomodulatory role, and this already has been published by our colleague in the essay journal. So this is the paper I recommend to read by Mofta. Thank you very much, all of you. Thank you for all the participating of our study and continuing work in this interesting domain, because we are opening a new domain. You know, we observed that before, the interaction with sickle cell disease patients and viral infection, very, very special. We observed that some viruses are hindered by the context of sickle cell disease patients. Even the homogeneous and homozygote and heterozygote patients show an important difference regarding their exposition to viruses. Thank you very much. Thank you, all of you.
Thank you very much, Professor Gonzalez, for this nice presentation. Now I will invite the other panelists who are presently here to come in front here. We will continue and we will ask them to give their opinion about these presentations we have followed and about the theme of COVID and sickle cell disease. I will invite Dr. Elisha Ozati. He's a medical doctor who is currently writing his PhD at MUHAS. I retained that he worked and wrote some papers on extrapulmonary manifestations of COVID-19 during and after acute illness in Tanzania, and is also a member of sickle cell disease technical working group associated to the health ministry. Welcome. We'll invite also Arafa Said, well known by the audience. She's a sickle cell warrior. She's the founder of Sickle Cell Disease Patients Community of Tanzania. And she worked as a community advocate and educator in Tanzania. And she contributes a lot in fundraising and charity events. That's very important. So I will start with you, Doctor. Can you, if you're in 5 or 10 minutes, your opinion on these?
Thank you very much, Prof. Good afternoon. Yes, I think we had great presentations on COVID and sickle cell disease, and I was impressed with the last paper. So I relate this with what the work that we are also doing here in Tanzania. So we and my team may be doing a study on COVID, trying to follow up COVID patients retrospectively, and then we follow them prospectively now for almost 2 years. And we have a data of more than 10,000 patients that were admitted, and our patients were only patients who were admitted in the wards. And I think you know the situation in Tanzania before. Unfortunately, our data is from March 2021, because previously we had no data on confirmation of COVID. So we are doing it in our big hospital, 5 hospitals, 6 hospitals in the country. That is at Muhimbili National Hospital, Pangai and Mloganzira, but also KCMC, Kilimanjaro, and Mbeya, Zone of Prosper in Mbeya, Northern Zone, and Ugando Medical Center and Dodoma. So in this now, after retrospective, then we are now analyzing our data for prospective. So we are following this patient that we do a different test, and actually we are looking at the presentations post and after COVID. And then we do CT scans of the chest. So we have like 800 patients that we are following up. We are doing CT scans of the chest. We're doing their echocardiography, ECG, we do renal function tests, lung function test. But again, also we look at the comorbids that are associated with COVID before, and during, and after COVID. So it is a big data, and we are done with the retrospective part, and we now continue to analyze the prospective data. And so what we have now in terms of sickle cell, fortunately, I think it's fortunate, we have very few sickle cell patients, probably because we are taking data only from March 2021. The previous data we didn't take because they are not confirmed to have sickle cell disease. So in our data, we have 9 sickle cell patients, and fortunately, none of them died, but all of them had severe COVID-19. That's why they were admitted. And we are using the WHO criteria to regard the severity of sickle cell disease in this patient. So we are using a cutoff of respiratory rate of more than 30, and partial pressure of oxygen of less than 94. That's according to WHO. And the more than 50% lung infiltrates by CT scan or chest X-ray. So we have found we have 9 patients, and as I say, we're fortunate that none of them died, but fortunately all of them are on hydroxyurea. And that's why I say the last presentation probably highlighted what we are seeing in these 9 patients that we are having. So really supports because we have a big data, and probably because we are taking only those who had confirmed sickle cell, COVID-19, and we started confirming our patients in 2021. So probably we have a big data that has not been confirmed, but they have the suspect of having sickle cell disease or having viral pneumonia or atypical pneumonia. So those ones, we didn't include them in our study. So I think we, given opportunity, we can look more into this data and see where on the sickle cell disease, and if we can follow them up and try to confirm the diagnosis. Yeah, so that's all I can say for now. Thank you, Prof.
Thank you very much. So we will continue with you, Arafa. In these 3 last years, how did you live with COVID? Probably you have got some personal experience, or what do you know about what happened in the other sickle cell patients during this period of pandemic?
Thank you so much, Prof. With what we have done at the sickle cell patients community, we actually worked together with our clinicians because most of the hospitals that had the camps for COVID-19 were the hospitals where our clinics are. So most patients were not able. We have been, we used more of telemedicine because we started calling because we know that we have a registry. So we called and gave awareness on what is really happening and how COVID can be, and made sure that they understand, and also schedule for them to how and where to go for a refill. So that's what we have been doing. But also we had a lot of cases that people are being sick because they're not being going to see their doctors on time. So this is what actually we have been doing. And I think it was a really hard time for us, but also we tried to use the telemedicine wisely, and because we'll have a proper registry. But still, looking at it, we have a good registry, but we're still saying that we are leaving people behind because we cannot reach to the rural areas where we can hear a lot of death and all that. But where we are here, we work very closely with our clinicians using the registry that is already here to make sure that they all know and what and how and where they should be going for refill. And that was done.
Thank you very much.
Thank
So another question: Do you think that the mortality that we probably observed during this COVID period was due more to the difficulty to access to the health center, or it was due to the susceptibility to the COVID infection? What's your opinion?
I think it's the same.
The same thing. So I will ask the same question to Professor Nachega and to Dr. Ashima Singh.
So I'll be very transparent and honest. I don't know. That's why we're doing the study. And even after doing the study, it's an observational study. So the result may still be confounded by a lot of factors. So we're gonna be very careful in our interpretation of the data we're gonna get. But it's really encouraging to see data presented by Prof. Gonzalez. So there is some light there that something is going on at physiopathogenesis level and the prior immunity, that we will be looking back also to those data that are emerging that Prof. Gonzalez presented. But again, we don't know. That's why we're doing this study.
Yes, thank you. Dr. Ashima, are you online? What is your opinion about this same question? And we would like to know, after hearing what Professor Gonzalez presented, what are your comments hearing these paradoxal results comparing to the USA results? Over.
No, I think it's a very interesting question, and it's hard to answer, as Dr. Nachega mentioned, because these are observational studies. But I think it'll be interesting when I hear your question. I think it'll be interesting to have a study where we compare mortality among individuals and see the causes of mortality among individuals with sickle cell disease who have COVID-19 and who did not have COVID-19, to understand if it was access to care that was one of the factors leading to death among individuals with sickle cell disease. But I think this is such a complicated issue, because even among individuals who have COVID-19, access to care could exacerbate deaths. So I think, I'm just trying to think of a study long answer short, I don't know the answer right now, but I'm trying to think of how we can design studies to understand if the factors that contribute to death among individuals with sickle cell disease. So maybe in future we can compare mortality within the sickle cell disease population, those who have COVID-19 and those who do not have COVID-19, and understand the causes. And I think what Dr. Gonzalez presented, that was very, very interesting in terms of the impact of hydroxyurea. And I was trying to remember what our data, because we did collect data on hydroxyurea, and I think we showed that if individuals who were taking hydroxyurea, they were at a lower risk of experiencing pain during COVID-19. And in US, we saw that a lot of patients with sickle cell disease, they came in with pain as presenting symptoms, and then when they were tested, it was COVID-19, that they had COVID-19. So there's certainly a very interesting finding, and hydroxyurea, as always, I think, is one of the very long-standing disease management strategies for individuals with sickle cell disease.
Thank you. Professor Gonzalez, yes, please give us your opinion.
Yes, if I may, I'm a virologist, I'm not a geneticist, so I'm a virologist, so this is a point of view of biology. So your presentation of both Dr. Nachega and Dr. Ashima are very interesting, and the observation some other colleagues mentioned. So what is very important in this observation about the SARS-2 infection to make the difference, the clinic and the epidemiology, that's two different worlds. What you are observing is about clinic. So the severity of the SARS infection in the clinic, this is clear. But what we are observing in terms of public health is that there is less people infected against the SARS-2 in the sickle cell disease population. So when they are infected, so there are other factors, the accessibility, the morbidity will play, but this population is less important than the population infected by this resisting of the SARS-CoV infection. So this is just to avoid this confusion between the severity of the SARS infection in the sickle cell disease patient, this is clinic, and the prevalence, which is less important in the sickle cell disease patient. It looks like less important because it's premonition or pre-immunity, etc. So this is two aspects. They are playing together, and it's important to keep this in mind to do further study. Thank you. Thank you for your attention.
Thank you very much, Professor Gonzalez. Can I give now the word to the audience here? Is somebody who wants to ask something about this session or some comments? We think that we have seen that Professor Nachega proposed a study on mortality in sickle cell disease related to COVID. I think that it would be a very great contribution to these paradoxal observations that we are looking between the North and the South. We suppose that, as Professor Nachega said, Africa was spared from this catastrophe of COVID. So we don't know exactly why, probably because of the pre-immunity and different environmental factors. And maybe we need to learn more about it, because one of the questions that I had for these experts in the infectious disease, we know when COVID pandemic starts. Can you tell me if it's finished or is still going on? Professor Nachega.
I mean, we all know that the WHO did declare COVID is not an emergency anymore, but that doesn't mean that COVID is over. The virus is around us. But the good news is majority of us being vaccinated, so we are protected. But people who have a risk factor still will still be able to get it and to be affected. So we should not be complacent, especially for those.
Just tell you that in DRC, we have just 300,000 people who are vaccinated.
So I'm talking here in general. Again, as I say, Africa, we just learned that there is some specificity on the continent that is really intriguing and very interesting, and that it's on our advantage. But in general, the virus is still there, and so we have to be clear about that.
Yes, thank you. Any comments, Professor?
Thank you, Prof. I think this is going to be a very interesting study, the one that Professor Nachega is proposing. But we're going to have to be careful to take into consideration a lot of factors. For instance, age of the patients. Our population of sickle patients is very much biased towards younger age. So let's say in our database now, 80% of our patients are below 18 years. That's going to be a factor in terms of risk. So that's one. The other thing is just readiness to access care. COVID patients are, the sickle patients are used to go to the hospital, while the normal person in the community, maybe they are not used to in terms of which hospital to go, how to navigate and things like that. So will that have an effect? I don't know. And the other thing, what we did during COVID, and Arafa talked about, we immediately engaged the telephone conversation. So we engaged all patients, provide education on what to do, not to go into gathering, or if you are sick, do this, do that. So did that impact infection? We don't know. So we have to start somewhere, but it's a complex topic.
Yeah, and that's why I did mention our study. We were very comprehensive to look at not just individual level factor, but also health system level factor. So it's going to be really a very thorough investigation before and during COVID. And then we're going to also engage some very sophisticated statistical analysis and causal inference to try to sort out to try to have some independent effect of each factor. So it's going to be, stay tuned. And again, I thank all the co-investigators in the room, the PI who are part of this study. And we currently also, we have 10 countries, but we did approach the Bill and Melinda Gates Foundation to get us more funding so we can include, as Julie Makani suggested, to include other countries, especially from Francophone and Lusophone. So we should know in the 2-3 weeks if we got more funding from Gates Foundation. So to try to have more countries on board. Yeah, thank you.
Thank you. Any other comments from the audience? Or I don't know if there are some questions online or comments.
Yes, if I may.
Yes, please. Go on.
Yeah, so if I may, so two, three things. I mean, the SARS-CoV-2 is the experience of the humanity, you know. This SARS, with all these variants, there's more than 25,000 variants. And one Omicron take the floor, you know. And we were very lucky. It's more infectious, so more potential to develop immune response in humanity, and less severe, more infectious and less pathogenic. We were lucky. This is hazard, totally hazard. It could be the opposite. And these viruses are circulating. So we have to cut the transmission. We are not out of the woods, not at all. You know, these viruses are there. In 2019, me and my colleague, we said, okay, we have this SARS-CoV just emerged in December in China. We are there for about 5 or 6 or 10 years. It will continue to circulate. And I mean, the other thing that's really bothering us is that these viruses mutating. There is mutation, there is variant, you know, mutation, and then stable mutations, variant, Omicron, etc. So this is really something we have to be aware and we have to be concerned all the time. The second thing, it's about age in the study population. Yes, the age is very important, and we are observing this switch, you know, in terms of public health and epidemiology between the severity in Africa with a young age And that was presented by Dr. Nachega, and this is a very, very important observation, rather than the whole age. Very, very interesting observation. And this is real. We're proposing the hydroxyurea. This is what we have to work, because it looks like this treatment, it could be a virucid, or it could play against the virus. And we know against, potentially against the coronavirus, but potentially other viruses. So, and the last thing, my last observation, when we are comparing the sickle cell disease patient infected with the SARS-2 and the general population, we have to pick up the general population with comorbidity. This will be reduced, you know, the impact, the real impact of SARS-2. So which type of comorbidity? This is a big question, but we cannot compare sickle cell disease patient with severe infection with the general population with SARS infection and severe infection. This, because there is a large, I would say large importance of comorbidity, and depending on which type of comorbidity. And the observation from the speakers about the role of the pain, it's interesting. This is a lead also. This is a lead about the severity of, I would say, viral infection, not only coronavirus infection. So why the pain? Why this potentially the severity? This is a very interesting question for me as a biologist also. Thank you.
Thank you very much, Jean-Paul. Just a question to Ashima. According to what Jean-Paul has said, you compare in your presentation between the Black sickle cell patients with the other Black group. And we said, I think that you have made the comorbidity, pneumonia and acute chest syndrome. Do you think that match well to do these two kinds of comorbidities as comparative data? Because the Black were the heterozygous, I suppose, not sickle cell patients.
Yes. So, no, Dr. Gonzalez raised a very good point that there are comorbidities in the general population that also impact outcome. So in our analysis that we did, we matched the sickle cell disease population based on comorbidities. And I mean, it's a long list of comorbidities, but it included asthma, hypertension, diabetes, heart failure, liver conditions, and I think pulmonary embolism, lung conditions. So we did match, just for the reason that Dr. Gonzalez said, that there can be differences. And the outcome that we saw, Dr. Chirol, the acute chest syndrome and pneumonia was an outcome, and we observed that individuals with sickle cell disease had a greater risk, even when after we compare to the general population, even after we match them on the clinical comorbidities.
Okay, thank you. A question from the audience.
Mine is a quick question. So I'm wondering whether we have been able to take advantage of the telemedicine program. And because I think evidence is already overwhelming in terms of how we have been able to sustain continuity of care of patients with sickle cell disease during COVID. But even before COVID, how are we prepared in terms of leveraging into that huge from which is already available to prepare this pandemic, but even now to sustain continuity of care, because it seems like the most cost-effective way of reaching out to patients with sickle cell disease. How are we planning? And this is not only to the Tanzania group, any other countries in Africa.
Thank you. The question is for all the panelists.
Thank you very much, Dr. Daima, for the question. I think, as you said, the evidence is there already that using the digital platform had a lot of impact as you saw in our sickle cell patient. I remember Rafa during COVID, because we have the clinic, we attend the patient, and we know them, and through the patient community, through Rafa and the colleagues, we were able to prepare the advocacy, the trainings every day. In the afternoon, we used to invite different sickle cell patients and talk to them about COVID-19 and how it can be prevented and what they need to do. And again, when they go to the hospital, they request prescription of at least more than at least for 3 months. So we have seen it has worked so much, and I think it is something that we really need to embrace and probably continue using it, and it can help us again to decongest our clinics, because as you know, the patient used to come to clinics every month. So by the use of this, now they can come up only after 3 months and collect. And this again, not only on the patient or clinic side, but again on the policy within the ministry, because, for example, when you go to insurance, initially they didn't want us to give medication for at least 3 months. They just wanted monthly. But after the COVID, and they saw the importance of having it, so they agreed to that. So I think the digital platform is the way to go, and actually it can help us with the patient, especially those who have no acute issues that need attention for the doctors, so they can come for the refill at least after 3 months. So we can still use it, and I think that's an important one.
Our warrior, you said that we use telemedicine during the COVID period. Are you still using it? Do you think that would be useful till now for the preventive? I don't know if we have got other pandemics, or for the other use between the sickle cell patients, communication, consultations, and so on?
I think I could say COVID has taught us a lesson. Without COVID, this room would not be enough today. Like, we would have all the speakers who are online here today with us. But I think with COVID, had made life easy somehow for us, because we all have to learn to use the telecommunication, like the internet and all that, the Zoom platform and all those platforms that are there. So it's something that we need to embrace, because it helped us using the time, and also it was easy because you just tell this person you need to go this time, get your medication, and go back home. So it's this. It took, the time consuming was not too big, because you know your appointment. It's not like the normal timing that we'll all go there and gather and wait for the doctors to arrive. But no, I know that I have to go there at 9:30. I collect my medication and go back. But also, it also helped us, because it's not all the areas we can reach by going, but through telemedicine, we could talk direct and make trainings with patients, but also speak to our clinicians on what should be done. So I think we need to embrace telemedicine.
Thank you. So it was one of the advantage of from this COVID pandemic. So Professor Nachega, some of the members of the teams of the study we plan to do on mortality are here. Can you have some recommendations, or we can ask what are their opinions in the realization of the study on mortality on sickle cell disease during this period of COVID, because I suppose there are probably some limitations. It would be good to try to know what are the limits.
Yeah, so we have here the PI of Tanzania, Prof. Balandya, and the PI from Zambia and Zimbabwe. Zambia, you want to?
Zambia, yes. Professor Chunda. Yes. Zimbabwe.
Yeah, Professor Chunda, just give some your own experience about the COVID and sickle cell on your site, and why you think you have been motivated to engage in this mortality study.
Thank you very much for the opportunity to speak on this topic. Just like everybody else, we've had all these questions about why, first of all, we didn't see so much of COVID in the African countries as we are seeing in the others, as well as why we saw a very, what I would call a low prevalence of the disease also in the population of children. And of course, our sickle cell disease patients. So we really don't have answers to those questions. And that is why really we're quite curious to learn what the impact is in our sickle cell disease population, knowing very well, according to the science, we know they should be affected much. They should have severe disease. And then also we need to understand the long-term impact of disease on those that did go on to have COVID. And so, yes, we are very much interested to participate just so we can be helped to understand what the effect really, or what the impact of COVID really was in our population. And just like was shared by our patient representative, we did notice a very low rate of patients actually reporting for care. And we wondered whether our patients were not coming because they were afraid of, contracting COVID within the hospital, or if they had died. I actually asked myself that question, could we have lost some patients? And even after the pandemic had, reduced, we noted our clinic, which was full of patients. All of a sudden, the numbers were very few. And it took quite a number of months before we could begin seeing the usual number of 50, 60 patients in a clinic. We're seeing much, much less than that. So this will shed more light actually on what happened really to our patients during that period. Thank you.
Thank you. From Zimbabwe.
Thank you very much. I think the biggest issue is we need to look at where our sickle cell disease patients are coming from. They're coming from the rural areas. In my country, they were decreased. There were soldiers on the road. People were not moving around, so they stayed in the rural areas. Whether that protected the patients or they died from COVID in the rural areas, now it's a bit difficult to answer. But the few anecdotal cases we actually confirmed COVID had quite severe disease, ended up in ICU, needing all sorts of things in terms of support. So it will be very interesting to participate in this research to then see the actual impact of COVID with us pulling our data. But the biggest challenge I think we have is, the biggest confounder is we were not able to actually test a majority of our patients whether they had COVID or not, because one, they couldn't afford it. There were embargoes on movement, so they were not actually coming to the hospital. At some point, these hospitals there was no service going on. The health workers were almost running away from patients. So once patients realized that is what was happening, they stopped coming. So it will be interesting to see what we find. Thank you.
Thank you. Professor Balandya from Tanzania.
Thank you very much. So we are excited. We have
cohort that Dr. Elisha is leading. Unfortunately, as he pointed out, most of the patients passed. But I think there's also experience from the pediatric side. So because he's taking care of the adults, so we engage also pediatrics. I think there were observations of a few patients there also. So we're looking forward to this so that our experiences are also on the map for the benefit of patients.
Thank you very much. Any other comments from the audience? Yes, we give you the word at the. Yes, we will. Well, so I will start with those who are online. Professor Gonzalez, have you 2 words to say? We are trying to go to the end of the session, please.
No, thank you very much for allowing me to participate to this very, very interesting session. And I think we are not out of the wood, as I said, you know, but what is interesting is we have to get all the experience we can from this SARS-2 and COVID-19, because there is so many things to learn about the risk of pandemic, the extension, the emergence of the virus, all these things we have to learn, and the treatment and the positive aspect we found for sickle cell disease, that these patients with the inflammatory phenomenon can fight against the virus infection. So that's my recommendation, more work and more things to discover. Thank you.
Thank you very much, Professor Gonzalez. Dr. Ashima, 2 words.
Yes, I think, thank you for allowing me to participate in this interesting panel. And I think we know that individuals with sickle cell disease are at risk of serious COVID-19 infection, and there's more work that needs to be done to understand the long-term impacts of COVID-19 for this population who already are at risk of end organ complications. But I think I also would like to reiterate what Salaam said, that we have some lessons learned, and I think telemedicine has been a positive experience for many patients. So understanding how access to care can be improved in context of COVID-19 or otherwise is an important area moving forward. Thank you.
Thank you very much. Professor Lucas, sorry, I don't jump to you, I'm you. 2 words about this possibility to the study on the COVID mortality in Gabon.
In Gabon, we are very happy to participate to this study. We will begin on now in July, and we are organized hospital center and 3 hospital center in Otogwe and in Libreville to conduct this study. And now we know that in our cohort patients, we don't have vaccinated patients because they are afraid to the vaccination, and they say that they don't see the necessity to do the vaccine because they are all sick, and they say that they will die. Parents say they want to stay with their children long time. They won't need to have some other problems like vaccination, COVID vaccination, and they are very afraid for vaccination. And at in COVID time, we have about 3 or 4 without registration, without regis analyzing. We know that in our cohort we have 4 patients who die at this time, and we will investigate to have more details about of sickle cell patients at COVID time. Thank you.
Thank you very much. Before giving you the last words, we have somebody online who would like to unmute his microphone, please. I don't know, is he? Can you just unmute it? Meanwhile, I will give my best greeting to my co-chair of Sickle in Africa, Professor Panli. Thank you for joining. Can you unmute somebody who would like to ask something?
Hello.
Yes, please.
Hello, please. How are you, Mr. Chirolo? It's Kofi Gustavo from Côte d'Ivoire.
Kofi, salut, bonjour. Please.
How are you?
Nice, thank you very much. Give your talk.
Prof. Nachega, I'm very happy to see you. So I just follow your presentation. It was very good. Just to tell you that I'm with you since Côte d'Ivoire, and I'm pleased to participate of this study. So I want you to be sure that we have already started the study, so that we are going to send you a message and to explain something according to this study. So I give my congratulations for all the participants, and just to tell you that I'm here and I follow you since this morning. Thank you very much.
Thank you very much, Professor Kofi from Côte d'Ivoire. Now we will have 2 minutes for your last, please.
Thank you very much, and I really appreciate for this great opportunity. I think as Professor Balandya said in the study that's going to start, I think we in Tanzania we had a very good platform to start with, because I said we have a data of more than 10,000 patients, and actually the good thing we have the whole country data that we took from national lab, so it be both adults and pediatrics. So I think we have a good platform that we can start with, and again include more hospitals. So the work will just be to have the results, and then we go back to the hospital to see what was going on with the patients. So yeah, so we really open up for collaboration, because we have the data on that. Thank you.
Thank you very much. The warrior.
One thing, but again, we should not also forget the long COVID, the long COVID among these patients, because as I said, in our cohort, we have 867 patients that we are following up now for 2 years, and we are trying to see how they are faring up in terms of their functionality in organ functions and their quality of life again. So I think that's one of the things that probably might merge in the study. Thank you.
That would be very interesting. Thank you. Warrior, the last word.
Okay, I can't emphasize enough that we should embrace the telemedicine, and if we're having no plan or we're not working on it, I think we should start working on it, because with this pandemic and a lot of airborne diseases can come anytime, and what if we come back with a second phase of pandemic? So I think we should embrace telemedicine and start having a plan for the future.
Thank you. Let's cross the fingers. For
no more pandemic.
No more pandemics. Professor Nachega, please.
No,
your last words.
Just 2 words to say thank you for the organizer for inviting me here, to Sickle in Africa, to Sparko, to Redac. I'm an ID, so I'm re-engaging with the world of dermatologists and so on. So it's been a wonderful experience. I would like also to thank the Lancet family for putting a high profile again through the Lancet Commission, this disease on the map again, and in terms of advocacy, resources, and more research. So thank you to the Lancet. Thank you.
Thank you very much. So we have just in time. I would like also to thank all the participants online and those who are here present to this last session in the afternoon. It's the last day. Usually we feel a little bit tired, but I'm seeing that you are you are still present here. That's a good thing. I would like also to express our feelings of grateful and friendship to all the team of MUHAS, because when we planned to organize this meeting, it was really a challenge between the consortium that was composed by Sickle in Africa, REDAC, Sparco. We were not sure that it will take place in this year. And the challenge was to the date that Yaiza from Lancet said it would be probably in July. So it was just for Professor Balandya and myself a great challenge. So we are very grateful to MUHAS for hosting this meeting, and we are grateful to Lancet Hematology for this new tool that will contribute to the advocacy, and we think that that will contribute largely to the implementation of the different programs on sickle cell disease in the world. So I will give the word to Professor Balandya for the next presentation.
Thank you very much, Prof. Yes, please, a round of applause to the panelists and chair. So now we are almost toward the end of the 2 exciting days. Before I give closing remarks, I would like to invite our very own Dr. Ritah Mutagonda, who's been sitting there. She was a rapporteur since day 1 yesterday, to give us a few highlights in a few minutes, and then I'll give the closing remarks.
Good evening. As Professor Balandya assigned me, sorry, can you hear me? Yeah, so I'm just going to give a brief summary of what has been the key points in these 2 days. So we had the honor of having speeches from the Vice Chancellor of Muhimbili, and then the US Embassy, who sent us the representative. And then we also had a speech from the Chief Medical Doctor of the government. And I would like to highlight some of the key issues which she was able to present to us. She was able to explain that there have been different efforts which have been made by the government of Tanzania to allocate funding to support sickle cell disease initiatives. And also hydroxyurea has been included in the essential list of medicine. So it's now available at the medical store department, and therefore it can be supplied to public health facilities. And then our first theme was on defining global strategies to improve outcomes in sickle cell disease, which a Lancet Hematology Commission. Here we had several presenters, starting with the first presenters who stressed the need for prioritization, unity, and education to be able to improve the outcomes of sickle cell patients in Africa. And then Dr. Frederick also pointed out on the need for the standardized protocol, which will ensure that the data which is collected in all these sites, sickle cell sites, is standardized. And through this epidemiological data, we can be able to see the evidence on the uptake of different sickle cell disease interventions and see the prevalence or the increase or decrease in mortality and morbidity among sickle cell disease patients. And then we also had a talk from Dr. Alexis, who also took us through the transformation of sickle cell disease and the experience of hydroxyurea for the past 40 years. And she also highlighted on the new therapies that have come up, which includes the bone marrow transplantation and gene therapy. A talk from Professor Nodu highlighted on the implementation of evidence-based intervention challenges and the need for education and training in order to prevent the complications of sickle cell. In her talk, she highlighted that we are adopting all these interventions to help in management of sickle cell disease. But then these interventions which are adopted, they are poorly implemented because the implementers do not have adequate knowledge to carry out the interventions which are in our guidelines. Therefore, she also pointed for development of a universal curriculum for training of healthcare providers. Professor Leon Shilolo also presented on the 12 goals and recommendations for the Lancet Hematology Commission, and he also underscored the need for unity between Anglophone and Francophone Africa. We had talks from the patient representatives, Ms. Arafa and Ms. Luimba. They pointed out their concerns regarding issues of accessibility, cost, availability, timing, and also the need to make sure that the basic care issues like hydroxyurea therapy should be made available to all patients with sickle cell disease. There were 3 patient appeals. One is to enable easy access and availability of advanced therapy should be available to all. And then the prioritization of the basic foundational care like diagnosis, for example, early infant diagnosis and pain management, this should be prioritized. And also to continue building a strong relationship between patient organizations, researchers, and healthcare providers. We had a talk from CONSA, where they have screened around 97,000 newborns. Despite several challenges, they're planning to scale up newborn screening to other African countries. And then Dr. Stella Malangahe highlighted to us the success they have had with newborn screening. So far, they have been, with regards to bone marrow transplantation. So far, 4 children have had bone marrow transplant, 3 have been discharged, and 1 is still at the hospital, but they are all doing well. And she also pointed out on how it was important for the government to commit itself to this process. And then we had a talk from Dr. Daima. She talked about advanced therapy for sickle cell disease and explained to us the 4 main components of sickle cell program at MUHAS, which are health advocacy, research, training, and partnership. In the panel discussion, we had key points. Among the key points were the psychosocial services are still poor among sickle cell disease children. There's a need for early identification of person's genotype rather than delaying to wait for premarital counseling. And then there's a need for Africa to start looking into genetic counseling programs which are tailored to fit the African context. And due to resource constraints, the African countries should do the mapping and see where sickle cell is highly prevalent for the initial resource allocation. But in the future, newborn screening should be accessible to all. And then we had a talk on global partnership for sickle cell by Dr. Isaac. In this talk, he pointed out that despite the adoption of interventions, there are many barriers to tackle sickle cell disease, which includes insufficient resource mobilization and inadequate funding. So far, there have been initiatives of resource mobilization by involving the World Bank, WHO, AFRO, and through the government fund allocation. Therefore, there was a call that there's a need to develop national sickle cell strategy and cost them so as to present them to the World Bank for funding. And then we had a talk from Dr. Colin, presented about the Pen Plus initiative, whereby the future plans are to expand to other African countries and continue to strengthen the provision of sickle cell care at the district level by dealing with mid-level healthcare providers. Dr. Kwaku from Novartis, yesterday he informed us that right now Novartis is producing hydroxyurea pediatric doses. They have a 50 milligram and 100 milligram tablets, which is now available in Ghana. So this is information for other countries to look for these tablets so that they are also available in their countries. And then with regards to Professor Akunle, he presented about the steps towards the Center of Excellence for Sickle Cell Disease in Africa, whereby we can benchmark on what is already available in Africa. We have several centers of excellence, even in Tanzania we have one. So we can benchmark on those which are available. And then we also need to make an argument to policymakers so that we can be able to establish Center of Excellence for Sickle Cell Disease. Sickle in Africa Consortium information was also the presentation was made by Professor Julie Makani. The emphasis was that the provision of healthcare can be done concurrently with research. So she presented on different research activities which are ongoing under Sickle in Africa Consortium. And then on day 2, we had 3 themes, starting with the first theme. The main key point is that not all patients do attend tertiary hospitals. Therefore, there's a need of bringing down services to the lower level healthcare facilities. The second point was that there's a need to involve patients and parents or caretakers of children with sickle cell disease in research so that they're aware of what is going on. And then there's a need to focus on the psychosocial therapy, which is currently underscored. And then we need also to find a better way of transitioning services from pediatric clinics to adult sickle cell clinics. Also, it's important to increase the visibility on the magnitude and the outcome of sickle cell disease, especially to politicians, so that they can be able to see how important it is to allocate funds to sickle cell disease. For the second panel discussion, the main key points were that there's the need to involve community health workers in sickle cell disease management, and the best time for premarital screening is during school age rather than waiting when people want to get married. And then for the case of newborn screening, it should come as a total package whereby those who will be diagnosed to have sickle cell disease will have access to drugs and all the advanced therapy that there is currently. There's also need to lobby for government support so that the government can allocate funds for sustainability of sickle cell disease management in the country. Another issue which was pointed out by AFREHealth is that patients should be involved at all stages and not only during the meetings. So patients should be involved at the government and everywhere where there's sickle cell disease issues. There's also a need to decentralize sickle cell disease intervention at the primary level so that it can be able to be accessible to the biggest population of sickle cell disease patients. And lastly, with regards to COVID and sickle cell, it was evident that telemedicine was useful during the pandemic. So we need to plan and utilize this platform further. And then the conclusion is that we still need to conduct further research to be able to see the outcomes of COVID-19 among sickle cell patients. And this study will also contribute to the knowledge for pandemic preparedness. Thank you very much.
Should say Ritah worked together with Dr. Martin Chikelea at the back in rapporteuring. I think they deserve another round. Just to clarify, because I think countries are interested in the hydroxyurea. So actually Novartis makes 100 and 1,000 milligram tablets. It's only that the 100 milligram can be cut into two halves. So you can have access to the 50 milligram. So ladies and gentlemen, I think we've come to the end. And this now marks the end of the 2 exciting days we've had here at MUHAS. So on behalf of MUHAS management and the organizing committee, may I express our sincere gratitude for your participation at this symposium. Your contributions in the presentations and panel discussions have greatly enriched the program. I thank all of you for participating. But as I do so, I must extend special thanks to a few groups that have worked very hard to make sure that this symposium was a success. Firstly, the Lancet Hematology. So your presence here really elevated our program. We thank you for agreeing to have us host the launch of this important commission, which I believe marks a pivotal moment in efforts to address sickle cell disease in Africa. Secondly, our sponsors. Specifically here, I wish to thank SADC, Professor Wonkam, Ambrose, Vicky and Mario, who are here with us today, for their support from the beginning of organizing, but also in supporting in terms of financial support for the symposium. To REDAC, Professor Shilolo, thanks very much for coming up with the idea and carrying it through during planning, ideas, and also funding support. Novartis, Kwaku, and team, thanks very much for everything you've done and for being here in person. Oxford Nanopore Technologies, we worked very closely with Roshila and Gerard. Gerard was here with us yesterday, but he already left. Platform Life Science and AFREHealth by Professor Jean Nachega, who just left. So they've worked very, very hard, and they provided a few grants to support travel of key members into this meeting and supported the last evening's networking event. Thirdly, and not least in any way, the organizing committee. You did a fantastic job. So a round of applause, please, to the organizing committee. So colleagues here at MUHAS, the Sickle Cell Program, from the Directorate of Research and Publication, our Master of Ceremony, the ushers, the 3 ushers, housekeeping, security, our drivers were busy shuttling us, ICT, accounting, rapporteurs, and the vendors. So JB Studios, thank you very much. The catering, printers, graphic designer who made this poster here. We thank you very much. We thank Lancet Hematology. They were with us during organizing and during those meetings. Redak, Professor Shilolo, Ash, we worked closely with Andrew Zepfer, Sadak, particularly Mario and Vicky, and all other colleagues who have worked behind the scenes. So your support was critical to the success of this symposium, and for this, we thank you. Ladies and gentlemen, I am thankful for the discussion we've had these 2 days. I hope that this symposium has provided an opportunity to strengthen existing collaborations and start new ones. I hope you leave Dar es Salaam with renewed commitment to enhance the speed of implementing the critical measures that we've known for decades to have the potential of improving outcomes of sickle cell disease in our continent. Further, as we strengthen these public health measures, it is our hope that the continent will not be left behind in the ongoing search for affordable and accessible gene therapies for sickle cell disease, especially ones that can be deployed across the health system in our continent. So with those few remarks, I wish you safe journey to those who are traveling. And I'm happy to declare that our symposium has come to an end. Thank you very much and Godspeed. So by way of update, I think Professor Shilolo, the rapporteur, and myself will sit together and we'll make sort of a statement, a short statement of the proceedings that can be used to communicate with the land ministries of health in the countries. I think the transportation arrangement is there as always. So the buses will be waiting for those who are going to the hotels. So again, thank you very much. I wish you safe travel and we'll see each other again. Thank you.